lining of the uterus, and it also relaxes smooth muscle of the uterus, which prevents contractions that could disrupt implantation and cause early pregnancy loss. The corpus luteum there also produces both estrogen and progesterone, which are important for supporting early pregnancy. If pregnancy doesn't happen, then the corpus luteum naturally regresses and it stops producing hormones, which leads to menstruation and sloughing of the endometrium and bleeding for the menstrual cycle. 3 steps in pregnancy: ovulation, fertilization, and implantation. So we said the ovary is gonna release the egg, that's called ovulation. That egg is gonna, the fimbriae of the infundibulum are gonna sweep across that ovary and help that egg get into the fallopian tube. As the egg moves through the ampulla, which is the widest section of the fallopian tube, is where fertilization occurs. You see those little sperm there. We're trying to fertilize the egg. Once that happens, it creates a blastocyst, and then there is a process of division called cleavage. And the egg continues to multiply. At this point, both genetic materials are in the egg. And if all goes well, that blastocyst will proceed down into the uterus and implant into the uterine wall, and that is implantation. So if we do a cross-section of that cell, you can see there are several layers of the cell. The trophoblast layer differentiates into the chorionic sac and eventually gives rise to the placenta. And the inner surface of the trophoblast are precursors for the amniotic epithelium. There's also an inner cell mass that you don't really see there that will develop into the embryo. For the third, fourth, fifth time, the most common site of fertilization is the ampulla, and that's just another depiction of that. All right. So we're gonna look at a little cross section from that trophoblast, that cell layer of the blastocyst. It's gonna develop into a couple of different things, like we said earlier. So here, the chorion and the amnion. And you can see that it's like an outer shell, like an outer barrier of protecting the fetus. So the most inner layer is the amnion, and that surrounds the embryo or the fetus. It's filled with amniotic fluid, and that serves as a cushion for the developing fetus. It provides buoyancy and a stable temperature. Also protects the fetus against physical trauma. The chorion, which is the layer outside of that, eventually forms the fetal component of the placenta. And we know the placenta contributes to the exchange of gases, nutrients, and waste products between mother and fetus. Before we go into the specific hormones, the chorion is involved in HCG, the human chorionic gonadotropin, which you know is a hormone that helps sustain pregnancy. So that's where the HCG is first under the chorion. All right. So first we're going to talk about estrogen. Majority of estrogen is produced by the ovaries. It is an important hormone for the maintenance of pregnancy. It plays multiple roles. One, it makes ovulation possible because it's part of the hormonal feedback that leads to that LH surge we talked about around day 14. It also causes thickening of the endometrial lining. It regulates the production of progesterone by the placenta. It acts on receptors in the placenta, signaling pathways to increase the production. It also stimulates maturation of organs such as the kidneys, liver, lungs, and regulates bone density in the fetus. It helps make the placenta grow and function. And it promotes milk development and breast enlargement in pregnancy. So it prepares a woman for the lactation period. Progesterone, also needed to maintain the pregnancy, is produced by the corpus luteum. So first it's produced by the corpus luteum and then by the placenta beginning around week 6 or 7. And as we said, it helps maintain that lining of the uterus so that the egg can implant. It also relaxes smooth muscle. Because it relaxes smooth muscle in the uterus, it also relaxes smooth muscle in other places, which can lead to annoying symptoms like acid reflux, constipation, indigestion. Progesterone inhibits uterine contractions, thereby preventing spontaneous abortion, which we will talk about later. And lastly, it says possibly it plays a role in the immune tolerance for products of conception. So when you do have possible spontaneous abortion or miscarriage, there may be products of conception left in the uterus. And there's a theory that the progesterone helps the body tolerate that the products of conception somewhat instead of rejecting it. So that's something that's been studied recently. Or it's involved. Human chorionic gonadotropin, or HCG. HCG is only made during pregnancy. It's only made during pregnancy. It is produced primarily by those trophoblast cells. After the fertilized egg implants the uterus, the trophoblast, like we said, multiplies to form the placenta. As the placenta forms and matures, it becomes the primary source of HCG. So while the HCG production begins with the trophoblast, it will progress to the placenta as the pregnancy goes forward. This hormone signals the corpus luteum to keep producing estrogen and progesterone, preventing it from regressing. Remember, we said if there is no fertilization of the egg, the corpus luteum will regress, and then you'll have a menstrual cycle. So if you have a fertilized egg that's implanted, the HCG is going to help keep that progesterone and estrogen going so that the corpus luteum does not regress and help to continue with the pregnancy. Corpus luteum will keep making those hormones until the placenta can take over. During the first 30 days after implantation, the concentration of HCG doubles about every 2.2 days. There's a red star there for a reason. During the first 30 days, the concentration will double every 2.2 days during that first 30 days. So that number should constantly be going higher and higher and higher that first 4 weeks of after implantation. And this is what we use in pregnancy tests. HCG titers of over 25, that's international units per liter, is a pregnancy test. That's the most qualitative urine test can detect. The most qualitative urine test can detect at that level. So if it's at 25 or higher, that's where the urine test can pick it up. HCG levels rise steadily, peaking around 8 to 11 weeks of gestation. And after this peak, typically start to decrease gradually. And why is that? Because the placenta is going to start to take over. So it kind of helps us know that the placenta is fully formed and is ready to function and properly take over that progesterone production. HCG levels may be low in ectopic pregnancy and spontaneous abortion, and we'll talk about that in more detail. HCG levels may be high in choriocarcinoma, which is a type of cancer that occurs in the tissues of the placenta or the uterus following pregnancy. So instead of a fetus, it turns into a mass, but cancerous. Very rare, but it can be aggressive. HBL, human placental lactogen. HBL is produced by the placenta and it modifies the mother's metabolism. It increases maternal glucose availability and provides nutrition to the uterus. It's capable of raising overall blood sugar levels and lowering insulin sensitivity. It antagonizes or interferes with the action of the mother's, the action of insulin in the mother's body, which is why it may play a role in gestational diabetes. HBL and gestational diabetes, maternal insulin level, nutrition for the baby. Prolactin. Prolactin production during pregnancy prepares and stimulates the mammary glands or milk glands in the breast for lactation once the progesterone levels fall at the end of pregnancy. It was produced by the anterior pituitary, and we can think prolactin, lactation, major role in milk production post-birth. Now, while prolactin is the major, the hormone that's probably going to produce more of the milk, remember estrogen has a role in that too. Estrogen enhances the effects of prolactin. So it contributes to the full development of the mammary gland, but think prolactin, milk production. Glucocorticoids. These derive from cholesterol, fetal adrenals, and the placenta. This hormone plays an important role in lung maturation and the biosynthesis of surfactant. If you know surfactant is needed in those little lungs so that the alveoli won't collapse when the baby breathes. And it's believed to play a role in the onset of labor. Glucocorticoids, I want you to remember lung maturation and surfactant biosynthesis, production of surfactant. Relaxin. Relaxin is produced in the ovary by the corpus luteum and in the placenta. It plays a role in supporting implantation. It peaks during the first trimester around week 10, and then it declines. And then it peaks again during the third trimester to prepare the body for labor. So initially it helps in supporting implantation. During the second peak, it relaxes the pubic symphysis and other joints while softening and dilating the uterine cervix to help facilitate delivery. So relaxin is going to relax the pubic symphysis and get the body ready to facilitate delivery. Oxytocin. Oxytocin originates in the maternal hypothalamus and posterior pituitary. It stimulates uterine contractions, oxytocin. We use synthetic oxytocin to induce or augment labor. If we need to push a labor forward, then sometimes we'll give mom oxytocin. It's also responsible for milk ejection reflex when the nipples are stimulated post-birth because that milk comes off. That's the review. So those are what we need to know for moving forward through this lecture series in terms of hormones. So what is the most common site of fertilization? Everybody. All right, during the first 30 days after implantation, HCG doubles every how many days?
2.2.
2.2. If you do a pregnancy test, the HCG titer has to be over 25 to test positive. Remember, progesterone relaxes smooth muscle and inhibits uterine contraction, also helps keep that lining thickened so we can have an implantation and maintain pregnancy. Estrogen helps the placenta grow and function, has some other functions as well. HPL increases glucose availability to the fetus. Lactation, which is a major role in milk production. Glucocorticoids, surfactant, lung maturation. Relaxin relaxes. It peaks in the first trimester with implantation, goes back down, peaks again in the third to get the body ready for labor. Oxytocin stimulates uterine contraction. Questions? Easy breezy. All right, that's the review. You just need to have that basis so you can understand moving forward as we go through the slides. So we're gonna move to confirmation of pregnancy.
It's just insanely strong. Struggled on it.
So what often is the first clue a woman has that she thinks she might be pregnant? Period, nausea, what else?
Breast tenderness.
Breast tenderness. So a lot of different things. A missed period is often the first clue. But there are some other signs that women may have before they even have a missed period. So we're gonna talk about confirmation of pregnancy, breast tenderness, fatigue, headaches, all kinds of things that women experience.
Chunky, that's chunky.
We're gonna discuss confirmation, as most people are not gonna go to the doctor immediately.
Delightful.
To the grocery store and pick up a pregnancy test. So, diagnosis of pregnancy. The presence of any of the following give us a diagnosis of pregnancy, and there are three. The first, detection of HCG in the blood or urine. Just talked about HCG. The second, pregnancy identified on an ultrasound. Usually a fetus can be visualized, or at least a yolk sac can be visualized by the 5th week of gestation, around 5 to 6 weeks. The third, fetal cardiac activity identified by ultrasound or Doppler ultrasound. You can hear fetal heart tones by ultrasound, usually around 6 or 7 weeks. For a fetal Doppler, sometimes you won't be able to hear it for maybe week 13. I don't want you to know those numbers specifically for the Doppler, the fetal cardiac activity. But you should know that you should see a yolk sac or at least something pregnancy identified on ultrasound around 5 to 6 weeks. So the pregnancy test, we just talked about this. All blood and urine pregnancy tests rely on HCG. HCG, we said, is only produced during pregnancy. So when we do pregnancy tests, we are relying on the HCG being detected, whether it's in blood or urine. Levels increase shortly after implantation and double how many, every how many days? 2.2. 2.2 days, you got it. If you have a 28-day menstrual cycle, you can detect HCG in the urine about 12 to 15 days after conception. Blood tests can tell if you're pregnant even earlier than urine. In the serum, 6 to 8 days after ovulation. Some sources say 5 to 7. So HCG is measured in international units per liter or milli international units per milliliter, so you'll see that on, for both of those. Lab standards can vary, but if it's less than 5 international units per liter, it's more than likely negative. If it's 25 or over 25 or more than likely positive. If it's in between, you probably need to test again. So if it's under 5, it can be considered negative. If it's over 25, usually positive. In between, take another test. By the time a woman usually misses her period, the concentration of HCG is about 100 international units per liter. There's no question. But it depends on how much HCG you're producing. And if you test too early or too close to your menstrual cycle, it may not pick it up. So you could be pregnant, but it just not go on the pregnancy test. You might not show up on the pregnancy test, depending on when you take it. On the ultrasound is the second way you can confirm pregnancy. And the ultrasound can confirm if it is progressing normally inside the uterus. We're gonna talk about pregnancies that implant outside of the uterus in a few. But you can see on the picture, small intrauterine fluid collection with rounded eggs around 4 to 5 weeks. Unequivocal sign of pregnancy is that yolk sac at 5.5 weeks. Around 6 weeks, the embryo appears. It's very tiny there, but a little tiny embryo. And then 7 to 8 weeks, you can start to see that amniotic sac, that amniotic fluid starting to build. So the transvaginal, the ultrasound can detect that gestational sac at 5 weeks. Around that time, the HCG levels will be between 1,000 and 2,000. We said fetal cardiac motion can be detected around 7 weeks. At that time, the average HCG level is around 17,000, but for some people, it can be into the hundreds of thousands. I do not expect you to memorize those numbers, except the weeks. Transvaginal ultrasound. Pregnancy duration. Typical length of pregnancy is counted from the first day of the last menstrual cycle. The first day of the last menstrual cycle. From the first day to the last menstrual cycle, to the time the child is born. That duration is usually around 9 calendar months, 40 weeks, or 280 days. 9 calendar months, 40 weeks, or 280 days on average. Only 4% of women deliver on their estimated due date or estimated date of confinement. Has anybody heard of estimated date of confinement? Anybody know what that means? It's like a medieval term. They, like, you were in the upper class or royal, they would like shuffle the mother off to be with the midwives until it was time to give birth, or and even afterwards for rest. So she was just like confined to a quarter of the house to rest, which is not like mom get that. So. But that's what data confinement is. All right. What I need you to know, full-term infants are born between 37 to 42 weeks. Full-term infants are born between 37 to 42 weeks. When are full-term infants born?
37 to 42 weeks.
Right, and preterm infants are born before 37 weeks. You're born before 37 weeks, it's preterm, and there are different levels to the preterm. I need you to know full-term is born between 37 and 42, and preterm is born before 37. You don't need to get into the specifics for this, but you can take it to your clinic with you. Preterm before 37, full-term between 37 to 42. All right, have you all done Nagel's rule? All right, so you know how to do this. So we're gonna do first day of the last menstrual period. First day of the last menstrual period. Gonna subtract 3 months from that.
add 7 days, and then add the appropriate year. To add 7 days, you need to know which months have 30 days, which months have 31 or less. So that's what the little knuckles at the bottom are for. February does not have 30 days. April does not have 31 days. June does not have 31 days. September or November do not have 31 days. So you need to count that. You can't. More than likely, you won't need to because you're gonna have these little wheels in your clinic. And you have a smartphone with an app on it and you can put everything in that way. But if you need to use it for maybe a test, then that's how you would count it, okay? Alright, so we're gonna practice. So last menstrual period was November 21st, 2023. So we're gonna subtract 3 months. That's gonna take us to August. We're gonna add 7 days. It's gonna take us to August 28th. Then we're gonna add the appropriate year. So we're expecting that baby to be born August 28th, 2024. Be here in no time. This is just another picture to help you remember. I don't know if it does. Beginning on the first day of the last menstrual period, subtract 3 months. Great Scott, you're probably too young for that. That's back to the future. Add 7 days, Nagel has 7 letters, and then add 1 year. That looks like bear. I don't know. This was not mine, but if it helps you, great, use it. But yeah. All right, so to determine gestational age, for the most part, we're gonna start with the estimated due date. We're gonna do that last menstrual period. If you know it, everybody's not gonna know when their last menstrual period was. So we'll use the ultrasound, the first ultrasound to confirm estimated delivery date. And with the ultrasound, what we're looking for is something called crown rump length, which you're gonna see here in the picture. That is from the crown of the head to the rump, the butt, not the extremities. Don't use the toes and the legs. Use from the head to the rump, okay? That's the best estimate of delivery date based on a reliable last menstrual period, then confirmed by the crown rump length in the first trimester. It is most reliable between weeks 6 and 11, plus or minus 7 days. Other measurements obtained between 12 and 20 weeks are reliable, plus or minus 10 days. And then after about 14 weeks, you're gonna have to use biparietal, diameter, femur length, abdominal circumference. And as you get further in the pregnancy, those measurements become even less reliable. So the best estimate of the delivery date is based on a reliable last menstrual period, if you know it, and then confirmed by crown rump. Yes, length.
Crown rump. Is that like, you need to know how it converts? Take a measurement and then.
No, just no crown rump. Yeah. And we're gonna look at the
Stickers.
picture. So this is pretty much is gonna be done by your sonographer anyway. So you're gonna look at the crown, measure it from the front, they're gonna get that length, and they're gonna give it to you, your provider, you're gonna use it, but you don't need to know how to do it. But again, head to rump, not feet. That's a good training, head to rump. The ultrasound, in addition to gestational age, can check for defects. So we can use it, like we said, for dating. We can look for neural tooth defects. We can check the ventral wall. We can look at limb lengths. We can look at profile, heart, stomach, placenta, umbilical cord, amniotic fluid volume. It can show us a lot of different things. It can detect fetal sex, which is what most people think about when they get an ultrasound, but that is not necessarily the purpose. An ultrasound abnormality, this is an example of an follicle, which you can see protruding out of the abdominal wall. And when the baby was born, what it looked like, where the organs are outside of the body. This is different than gastroparesis, which is when those organs don't have a sac. You can see this baby has a sac. One of my friend's grandsons was born with gastroparesis, so his intestines and all of his organs were on the outside. He adjusted, he did really well, but he ended up dying from a UTI complication, which is really sad because he had went through all of those surgeries and adjusted so well, but then a complication from a UTI caused him to pass. So this is one abnormality you might see on the ultrasound. Clinical pearls, 3 things to confirm pregnancy: HCG, ultrasound, cardiac activity on Doppler. Nagel's rule. Estimated due date. First day of the last menstrual period, minus 3 months, plus how many days? 7, plus 7, add a year. Gestational age, we will confirm by crown rump length. That is fun to say. Crown rump length measurement, which is best during the first trimester. Any questions? Again, this is kind of review basics. Okay. Okay, we'll start the 3rd, and then we'll take a break. Do you want to take a break now? All encompassing management throughout the pregnancy. Entire journey of the pregnancy.
She'll measure its crown length.
We're gonna start with preconception care. Ideally, we would begin before pregnancy with preconception counseling to help identify risks related to maternal conditions, family history, genetic disorders prior to pregnancy. It can also provide patient education regarding recognition of early pregnancy, complications, promoting healthy behaviors. It can provide nutritional counseling for best pregnancy outcomes. For example, in red, you'll see folic acid. With the CDC recommends all women of reproductive age should get 400 micrograms of folic acid every day to get enough folic acid, as it has been shown to reduce the risk of neural tube defects, like spina bifida. Why do we do it for all women of reproductive age and not just those who want to become pregnant? Because most pregnancies are unplanned. Most pregnancies are unplanned. About half are unplanned.
No.
They recommend folic acid. You should know folic acid is recommended at that level, 400 micrograms daily. You do need to know that. Major birth defects of the baby's brain and spine occur very early in pregnancy, 3 to 4 weeks after conception, so way before somebody even knows that they're pregnant. That's why it's important to get that folic acid. If a woman has had issues with neural tube defects in like a previous pregnancy, she'll probably be on a higher dose, but for testing purposes and for average, most patients need to be on 400 micrograms. So some of this, most of this lecture was from the Hacker and Moore book. So I've had to go back through currents and redo some stuff, but I did leave this in here because it gives some good counseling things you can talk about with your patients. This is for you to take with you when you go to your women's health rotation. This is not for you to know for the test, but it does have a lot of good information on there about what you can talk to in preconception counseling if someone comes in and they want to discuss becoming pregnant or getting pregnant. They're trying to work on family planning. Different questions you can ask, different things you can focus on in your exam, labs to order, health behaviors, things that will help relieve stress, and so forth. So that's just for you to take with you as a resource. So we're gonna go into prenatal care. The objective of antepartum or prenatal care is to ensure that every wanted pregnancy culminates in the birth of a healthy infant without impairing the health of the mother. Inadequate or late prenatal care is associated with the risk of prematurity and low birth weight infants, which is a major cause of infant mortality in the U.S. That is our objective when we do our prenatal care. 3 basic components. 1, early and continuing risk assessment. We need to do our history and physical, order our labs, assess gestational age and well-being. 2, health promotion, which is gonna provide information on proposed care, enhance general knowledge of pregnancy and parenting, promote and support healthy behaviors. And 3, medical and psychosocial intervention and follow-up. You need to manage and treat existing illness. Sometimes you might need to help provide social or financial resources or give necessary referrals for those services. Or consults if needed. All right, so you're gonna see this slide many times. A preconception visit, like we said, is ideal. Now we're gonna talk about from conception to 28 weeks. And during that time, the mom is gonna be seen about every 4 weeks. We're gonna concentrate on the first prenatal visit for the next few slides, and then we'll talk about 29 to 36 weeks, and then 37 weeks to birth, and then the frequency of those prenatal visits. So from conception to 28, it's every 4 weeks. All right. Just talked about this. First prenatal visit. Someone thinks they're pregnant. What are the 3 ways we can confirm pregnancy? 1, 2, 3. Fetal activity on the Doppler. Yeah. Very good. All right. So during the visit, we're gonna obtain our comprehensive history and physical. And you wanna keep in mind as you look through this, everything isn't for the first prenatal visit. Some of this is just in general, it might not be seen till later on in the pregnancy. But let's start with the comprehensive history. We're gonna do a medical history. It's gonna ask about Hep B and rubella vaccinations. Are they up to date? A reproductive history. Have they ever had a baby before? Was that a preterm birth? Did the baby have a low birth weight? Did they deal with preeclampsia? Did the baby not make it? Was it born stillbirth? Were there any congenital anomalies? Did they have a C-section? Gonna get family history, genetics, background, nutritional history. What's your diet like? What do you do for exercise? Your basic key questions, things you already know and do very, very good. Psychosocial, that a strength for domestic violence, up to 10% of women are abused during pregnancy. We're gonna talk about this more in loss and pregnancy, traumas and pregnancy complications. How the placenta can sometimes separate because of the trauma to the abdomen. For our physical exam, we're gonna do a BMI, baseline BMI, because that weight is gonna change during the pregnancy. We're gonna get our baseline BMI. Some normal pregnancy findings might be a systolic murmur, palmar erythema, linea nigra, which we're gonna look at, striae gravidarum, which we're gonna look at, melasma, which we're gonna look at, edema, water retention, swelling. The breast exam. This will allow you to discuss breastfeeding intentions. Do you plan to use formula? Do you plan to breastfeed? You're gonna do a pap smear and document or obtain a pap smear. Or either look at a documented one. You might need to do STI testing. You want to check the cervix. So we talked about vaccinations being up to date. If they are not up to date on their vaccinations, they're seronegative for rubella, you need to vaccinate post-birth. You cannot give the rubella vaccination during pregnancy. You cannot give the rubella or German measles vaccination during pregnancy. If they are seronegative, meaning they've never been exposed or developed any immunity towards it, you need to vaccinate or encourage vaccination post-birth. Rubella can lead to serious health issues, arthritis, encephalitis, miscarriage, birth defects if contracted during pregnancy. So it's important to know. Newborns are particularly vulnerable to infections, so ensuring maternal immunity helps protect them during the early months of life. Hep B is safe to give during pregnancy if the patient is at high risk. We're just gonna look at a few of the dermatological conditions you might see. Linea nigra is a dark line that develops across the pelvis during pregnancy. It usually extends from the belly button to the pubic area and is caused by an increase in hormones. Typically, that little line will fade once the baby is born. Striae gravidarum, or stretch marks, develop on the abdomen as well. Generally, they become visible during later trimesters, around 6 or 7 months of pregnancy. But for some women, they'll start to see them as soon as their belly starts to grow. Some people think it's a genetic element to that. Striae gravidarum or stretch mark. And then the last term thing we're gonna look at is melasma, which is a skin condition that appears during pregnancy, often called the mask of pregnancy. You can see there on the cheek. It can occur at any point in the pregnancy, but usually during the second and third trimester. Some women have small spots like freckles, and some have big spots, blotchy patches. This usually appears when there's a steep rise in estrogen and progesterone levels, which stimulates excess melanin production, hyperpigmentation. Thus, it is especially common in darker skinned women and those of Asian and African descent. Sunlight can make this more noticeable. If you're exposed to the sun or on a, what do they call them, baby moons? You have a vacation before your baby's born, might come back with. Why don't we take a break and then we'll get into divinity and parity. So I'll see you do one or you can see two or whatever. So this is how we remember, how we can kind of look at the information in obstetric history quickly. The G is the number of times a female has been pregnant, including the current pregnancy. So the total number of pregnancies, including the current pregnancy. Parity, or P, is the TPAL part. So some people just use the P, which is the number of children previously born, the outcome of all pregnancies. So it may just be G1P1 or G3P1. They may be lost 2 or had a miscarriage. But for some, they'll go through the entire GTPAL. The TPEAL stands for different things. The T is term. Full term birth. What do we say a full term birth was?
37 to 42.
37 to 42 weeks. So anything equal to or greater than 37 weeks is a full term birth. Premature births are under 37 weeks. But for this, the P is 20 to 36 weeks gestation. Premature births are 20 to 36 weeks gestation. The A, abortion or miscarriages, defines anything less than 20 weeks gestation. And the L stands for the number of living children, but refers to the number of live births an individual has had. Each child is counted individually. So if there's a pregnancy of twins, that will be calculated as a G1 because there is one pregnancy, but a L, how many? 2, because 2 babies were born, living children. So we're gonna look at this and then we'll do some examples. So a G6P4024 would be 6 pregnancies total. The P, the TPAL, the T, full term births, that patient had 4 full term births. 0 premature births, which is 20 to 36 weeks. She had 2 miscarriages, which were under 20 weeks gestation when she lost them. And a total of 4 living children. G6P4024. This you do need to know. GTPAL, there will be a test question, I'm sure. And it probably, it may be on your pants, I'm not sure. Yes. So P is parity, it stands for the TPAL. The TPAL is the P, it's the whole P. Now, you can either do, you could have said G6P4, but for information purposes, if you wanted to break it down, she had 4 full-term births, 2 miscarriages. So she was pregnant 6 times, lost 2, had 4 living children. So you can either say G6P4, but if you want the full details, then it would be the 4024. Make sense? Yeah.
You said for the living children, that's just number of live births, even if they.
So she had a live, she had a baby, but then it died, like in stillbirth, that's still. But they. Versus the miscarriage, where she lost the baby early, that goes under the stage. Twins counted individually, 1 pregnancy, each baby is counted in that bill as living children. That make sense? Yeah.
Explain that again. Child.
Huh?
You mean they were born living, but if they died after, they're not gonna count it.
Correct. So like, let's say that she had 4 living children, but then she had a stillbirth. Then you would consider that she still had the baby. She had a live birth. But if the, not saying stillbirth, let's say the baby died a couple of weeks later or something like that. That would still be considered a living child.
But so it's just live birth.
Live births. Live births. Stillbirth's kind of confusing because it doesn't really go under abortion or miscarriages because it's not under 20 gestation.
It's usually we would put it under the full-term birth, but it wouldn't be represented as a living child
Living, yeah. That makes sense.
because they made it to
They
term.
did. They just did.
They did.
Yeah.
So sad.
Literally sad.
You said it was sad.
That's so sad.
It was sad. All right, let's practice. So what is the patient's GTPAL? Jen is pregnant for the first time. G,
1.
P. Tara is pregnant for the first time with twins. G,
1.
P.
2.
She's pregnant for the first time. How many babies does she have? 0.
So what is it?
Amina is pregnant for the third time. She had twins at 36 weeks and a son at 38 weeks gestation. What is her G? 3. All right, let's break it down. The T, how many full-term did she have? What is full-term birth?
37.
So how many full-term births did she have?
1.
Did she have any preterm birth?
2.
1.
1. Did she have any abortions or miscarriages? And how many living children does she have?
3.
Good. So hers is G3, P1103.
Yes.
G3, P1103. Or G3. Anne is pregnant now. Anne had 1 miscarriage at 12 weeks. She had a son born at 36 weeks, a daughter born at 39 weeks, and a son born at 25 weeks that died shortly after delivery. Fun time. Let's see what we can do this one. What's her G?
5.
She's pregnant now. She had a miscarriage. She had a son born at 36 weeks. She had a daughter born at 39 weeks. She had a son born at 25 weeks that died shortly after delivery. T, Full term. How many were full term?
One,
One. Premature,
two,
two, 36 weeks and 25 weeks. Abortion or miscarriage,
one,
one. And how many living?
two,
Two. G5, P1, 2, 1, 2. G5, P1, 2, 1, 2.
yeah.
The sun shall be served, 25, and die, not counting the-
Ah, yes, it is. What's a three?
Living.
So it's one, two, and three.
Women's carriage is 12 weeks, unborn at 36 weeks. Premature. Daughter born at 39 weeks, and a son born at 25 weeks that died. One, two, it should be three.
Yeah, she had a line for her.
It should be three.
Yeah, I heard their rationale, that makes sense. It says living children.
I need to look at that, but I got this offline.
Like
I don't know about It's kind of like
Yeah,
the living.
they're alive, but
Yeah.
it was a line when it was born, and that's,
So that would be a free term.
I think I would count it in the pre-terms and not the living.
but it's a living.
It was living.
Born.
I think that out. It should represent the living, like live birth.
Yeah,
ACOG has it as live births.
Live births.
and it wasn't alive when it was born.
So it was live.
When you,
Yeah.
yeah,
So three.
So it counts.
Yeah, three. All right, let's try this. Whoa, 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 I'm going the wrong way. All right. All right. So pregnant now, one miscarriage of 12 weeks, some born at 36 weeks, daughter born at 39 weeks, some born at 25 weeks, that died shortly after birth. 1, 2, 3, 4, 5. Morbidity. CPAL, full term, 1. Premature. 1, 2. Premature, 1. Son born at 36 weeks. Son born at 25 weeks. Why do you have premature as 1?
should be two. Number 20.
That's preterm. What is the preterm? It's born under how many letters? The miscarriage is born, or losses at what?
120.
20 weeks or less. So preterm is 20 to 36 weeks, so that 36 week is still counted in the preterm. The 25 week is counted in the preterm. An abortion or miscarriage, 1, because of the one that she miscarried at 12 weeks. And then we're doing live births. The son born at 36 weeks, the daughter born at 39 weeks, and the son born at 25 weeks, even though he died shortly after. Questions? I know that was. confusing. Okay, we're gonna practice more. All right, labs. What labs do we need? HCG quantitative measure, either through serum or urine. The quantitative is the exact amount of HCG present in a sample versus qualitative, which simply says, yes, there's HCG in the sample or not. So we want to get a quantitative measure, how much HCG is there, because that will help us know if we're going in the right direction, because HCG during the first 30 days of implantation doubles how many every day, how many every 2 days?
2.2.
2.2, doubles 2.2 in concentration. We are also going to order a hemoglobin hematocrit. Up to 1/3 of women will have anemia during their 3rd trimester. So we want to kind of get a baseline for that. You might also order a urinalysis of culture, serum folate level, glucose, blood grouping or typing, antibody screening. If the patient is Rh negative, they'll need RhoGAM, which we're going to talk about in a second. FPI, we We might test for STIs depending on exposure and risk, HIV, syphilis, gonorrhea, chlamydia. And diagnostics, we're gonna get an ultrasound to confirm that intrauterine pregnancy. If the patient is Rh negative, we're giving RhoGAM at 28 weeks and post-birth to prevent sensitization, which we're gonna talk about in a second. You will also need to give RhoGAM anytime there's bleeding. 28 weeks and at birth and anytime there's bleeding. RhoGAM at 28 weeks and post-birth, anytime there is bleeding. The state of Maryland requires syphilis testing. HIV testing and counseling is recommended, but only voluntary. And testing for gonorrhea, chlamydia, and TB based on risk assessment. So let's talk about the RhoGAM. So RhoGAM prevents the formation of active antibodies against Rh positive erythrocytes or red blood cells, which may enter the maternal bloodstream during pregnancy with the Rh positive fetus. We're gonna look at on the next slide. It is generally given between 26 and 28 weeks gestation, but also anytime there's bleeding, suspected hemorrhage, threatened abortion, or an abdominal trauma. So 28 weeks, post-birth, bleeding, suspected hemorrhage, threatened abortion, abdominal trauma. Anytime there's suspected bleeding or hemorrhage. So let's look at it. So you got a Rh negative woman and a Rh positive man who conceive a child. Mom is Rh negative, but now she's pregnant with Rh positive fetus. The cells from the Rh positive fetus enter the woman's bloodstream. She becomes sensitized, and antibodies start to form to fight the Rh positive blood cells. Well, at that point, it's not really gonna do anything, but it will matter if she is pregnant again, because her maternal antibodies are gonna attack the fetal red blood cells. So Rh incompatibility happens when there's an Rh negative mom and an Rh positive baby. It can lead to complications if the antibodies attack those red blood cells in the next pregnancy. So we're giving RhoGAM at 26 weeks, post-birth, and anytime there is suspected bleeding or hemorrhage. Some of the counseling we're gonna do, we're gonna talk about diet, vitamins, exercise, weight, and lifestyle, all aimed at risk reduction and improving pregnancy outcomes. So these are things you'll be doing in your counseling and patient education during the first prenatal visit. Pattern of weight gain. So first trimester, they gain about 3.5 to 5 pounds. But then as you move forward, you gain about 1 pound a week. So you can look at the pre-pregnancy weight category and then the recommended weight gain in the second and third trimesters. Recommended range of total weight here in the middle. Some people say, I'm eating for 2. You don't necessarily want them to gain that much weight, so it really depends on where you were pre-pregnancy, how much you should be gaining.
Oh, I'm gonna be saying
This
that
I
all the
do not
time.
want you to memorize, but it's just information. And you should be, baby itself is probably gonna
Weirdest
weigh
craving.
5 to 10 pounds.
I'm gonna be eating.
Placenta, amniotic fluid, and breast tissue can weigh anywhere between 2
I
to
already
3
eat what
pounds.
I'm doing.
Blood supply is about 4 pounds. Stored fat for delivery and breastfeeding, about 5 to 9 pounds. A larger uterus can weigh 2 to 5 pounds, so in total, we're looking at about 25 to 35 pounds of weight gain, during the pregnancy. An adequate weight gain would be if you gain less than 20 pounds, which could be associated with low birth weight infants or other perinatal complications. So what kind of meds are we gonna talk about that first visit? So typically a prenatal vitamin. There's sulfate if the patient is anemic. If the patient's on levothyroxine or Synthroid, you need to check their TSH every trimester. You may need to increase their dose as the pregnancy progresses. And then you need to think about how to taper that after the baby's born. If they have a history of HSV, a herpes simplex virus, you want to offer oral suppressive therapy starting around 36 weeks gestation. If you get close to the finish line, if you can give a cyclovir or valacyclovir, that we'll see again in another lecture. All right, nutrition. So we talked about eating for two. Typically about 300 additional calories per day per fetus. So if you have twins, that's 600. You have triplets, 500 additional calories per day during lactation. The moms need a lot more calories as they're breastfeeding. They're burning it off super fast. Folic acid supplementations prevent neural tube defects. And supplementations prevent anemia, and the prenatal vitamins, kind of a repeat of the other slide. The first prenatal visit is an opportunity to review medical, reproductive, family, genetic, nutritional, and psychosocial histories, which we talked about earlier. Moms who have existing health conditions like diabetes, hypertension, HIV, or obesity, if they're pregnant with multiple fetuses, if they're at an advanced maternal age, 35 years or older, or if they're young, the maternal age of 17 years or younger, they have an increased health risk for mother and fetus labor. The treatment is dependent on specific risk. The biggest risk factor for a teen mom is delaying prenatal care, or worse, not getting care at all. 7% of teen moms do not seek care. Teenage bodies are still growing, they're still developing. So young women should be cared for and monitored very closely during pregnancy. Nutritional counseling, including healthy weight gain, prenatal vitamins, and folic acid intake tends to be a focus. That ultrasound abnormality we saw was that omphalocele or the gastroparesis. This is very common in young mothers. Very common in young mothers. The friend that I was talking about, her daughter-in-law was 20 years old when she had that baby in the hospital. So she was a young mom. But you should be aware of teenage moms and then moms of an advanced maternal age. So our follow-up visits, going to be looking at several things: blood pressure, weight, checking the urine for glucose and protein. We're going to be doing fundal height measurements, which we'll talk about, fetal heart rates, assessments of fetal movement, looking at fetal live presentation and position, which we'll talk about, diabetes screen. We're going to talk about that in more detail. Group B strep screen at 37 to 36 weeks. Going to talk about that more. STI rescreen if they are at risk. Education on breastfeeding, circumcision, preterm labor, danger signs, labor signs. And you can encourage childbirth prep and parent education classes, mod, whatever, new mom classes, new parent classes, things of that sort. So moving, yes. If there's what? I don't know. Not for sure. When I was looking at the omphalocele and looking at the different, looking for different pictures of it, I saw that, but I'm not for sure why. All right, so again, like I said, we're gonna see this frequently. Frequency of prenatal visits, conception to 28 weeks. We're seeing mom about every 4 weeks. So we're gonna talk about timing. So in the medical world, we use weeks. Months is more of a layman's term, or 4 months, or 5 months. In medical, when you're on your site, you're gonna be talking in terms of weeks. The first trimester is 1 to 12 weeks. Second trimester, 13 to 27 weeks. Third trimester, 28 to 42 weeks, and then you have a baby. Now you can see a little bit of a discrepancy here because this one says that first trimester is from 1 to 13. So just know on average that first 1 to 12 weeks, I would never ask you something between like a 12 and 13 or 27 to 28, like something that's right there on the border. It'll be something for sure. First trimester, second trimester, third trimester, you'll know. what I'm asking for. But this is our timing, pregnancy week by week. This is also a lot of different resources, a lot of different things, what size the uterus is in a non-gravid, someone who's never had a baby, what the size is at 6 to 8 weeks. A lot of people like to use comparisons of fruit. Oh, the baby's the size of a grapefruit, baby's the size of this and that. I want you to know bimanual exam is an accurate indicator prior to 16 weeks. Finger, abdomen, and you're feeling for that uterus. That gives you a pretty good indicator of about how big that uterus is if you're 16 weeks or less. These are just numbers. Don't want you to memorize them because you'll see that it's different. Here it says that the grapefruit is 5 months. There it says that it's 12 weeks. So I don't want you to memorize that. That's just for reference, just so you can see. Same with this. Just an idea of what it might look like. So it says it's orange pre-pregnancy on the previous slide. It says that the lemon was pre-pregnancy. So, you know, fit for that. 12 weeks, grapefruit, papaya at 24 weeks, watermelon at 40 days. So that's the uterus size through pregnancy, just for an idea. And that helps us with fundal height. So fundal height in gestation, this is a measurement that helps us estimate the size of the fetus during pregnancy. Predictable pattern of uterine growth. Defined by the distance of the pubic bone to the top of the uterus. At 20 weeks, typically, the fundus, remember we talked about the fundus, the height of the uterus and all of that, is at the umbilicus. You see that there, the umbilicus is about 26 weeks. At 36 weeks, that height is gonna be at the zygote process. So 20 weeks, umbilicus, 36 weeks, zygote process. 20 weeks, umbilicus, 36 weeks, zygote process. Last time, 20 weeks, where is it at? 36 weeks. All right, measurement correlates well between the 22 and 34 week marks. After that, it's a little bit different. So we would expect it to match. So if you're taking the measurements from the pubic bone to the height, that measurement should correlate. So if they're about 22 weeks, it should be about 22 centimeters. 34, 34. And so forth. McDonald's method at each prenatal visit, which is how that measurement is done, which you're gonna look at here. I'm not gonna push play, but if you watch this on your own, they'll show you how to take that measurement, which you're gonna learn when you're on your rotation. You can see it up at the top as well. You're gonna have to take to measure that distance between the symphysis pubis and the top of the fetus. Okay. And again, 20 weeks, 36 weeks, and you'll see that 40 comes back down, and that's because the baby is starting to make a descent towards the opening. So this video, if you want to watch that, it will show you how to measure fundal height. All right, so when did we say the first trimester was?
To 13 weeks.
About 1 to 12, 1 to 13 weeks, yeah. So we're gonna do some different screenings. Around 9 to 12 weeks, we're gonna do a serum analysis with a beta HCG. We're still testing that HCG because we wanna know what the levels are and make sure that they're doubling like they should be, and staying where they should be, or going down. We need to do that measurement. We're also gonna do an ultrasound to measure the nuchal translucency, which is a measure of the thickness of fluid buildup at the back of the neck of the developing baby, which we're gonna look at in the next slide. This area is thicker than normal. If it's thicker than normal, it may provide some risk of chromosome abnormalities or aneuploidies like Down syndrome, trisomy 18, 13, or heart problems. So we'll see that on this picture here. Very, very tiny, but that's a normal nuchal translucency versus this larger area here, that is abnormal. That's what we're looking for. Like we said, it is the ultrasound to measure the clear translucent space at the back of the baby's neck, the nipple fold. All babies have fluid behind their neck. The fluid tends to build up more during the first trimester in babies with chromosomal or genetic conditions, resulting in the space to be larger than average, which is usually done between 11 and 13 weeks. It is not diagnostic. This is a screening. It will help you decide if you need to go with further testing, like a chorionic villus sampling, CBS, or intrathecal. So if we see that, we know we need to order another test. So let's talk about those specialized tests. The CBS, or chorionic villus sampling, is a diagnostic test with high levels of detection. High levels of detection accuracy, 98 to 99%. It is performed at 10 to 13 weeks. It detects chromosome abnormalities and genetic disorders, cystic fibrosis, trisomy 21. Also provides DNA sampling for maternity testing. You are not the father. Primary risk of miscarriage is 1%.
R.I.P. Haven't we both died?
I missed that show.
Yeah.
What was that, Dr. Phil? Was that Dr. Phil? Yeah. Who? Maury.
And Jerry Springfield also dead.
Oh, Jerry Springer.
There's two methods of collection.
This is
I did say Springfield.
You can do a transcervical collection, where the ultrasound gives you the thin catheter through the cervix to the placenta to suction out those cells. Or you can do it transabdominally, where the ultrasound guides a long, thin needle through the abdomen to the placenta to remove the sample of tissue. This is similar to amniocentesis, but a little bit different. Amniocentesis, you can't do until 15 to 18 weeks. So this one you can't do until a little bit later. For this one, you're gonna do the aspiration of the amniotic fluid from the amniotic cavity. It is the most common invasive fetal testing procedure. It is the most common. More common than CVS. It is performed also to diagnose or exclude fetal aneuploidy and fetal genetic or biochemical risk. The risks are lower though. Risk of loss is 0.13% compared to 1% on that CVS. You have a risk of amniotic fluid leakage, which is 1%. And there's a video at the bottom if you want to watch that, see how it's completely different. So CVS and amnio, they're the same, but different. They're both prenatal diagnostic tests. They both detect genetic disorders. They're both relatively safe. They both determine development of the fetus. They both check for chromosomal abnormalities, and they're both informative for patient counseling. But some of the differences. Gonna get a sample of placental tissue on the CVS versus amniotic fluid on the amniocentesis. CVS you can do sooner, 10 to 13 weeks versus 15 to 18 on the amnio. The CVS we said has a higher risk of miscarriage. The amnio has a lower risk, 1% versus 0.13%. CVS you can get transabdominally or transcervically. The amnio you can only do transabdominally. For the CVS you would use for higher risk patients, if you're concerned about something, you have a higher suspicion of, index of suspicion, then the CVS may be the one you want to get. For lower risk patients, you might get amniocentesis. Remember, amnio is the most common. And then you can look at that chart if you need just extra resources, nothing to memorize on that chart. So another option is a non-invasive prenatal screening or non-invasive prenatal test, NIPT or NIPS. This estimates the risk of conditions by analysis of fetal DNA circulating in the maternal serum. So this is non-invasive way to test for Down syndrome or trisomy 18. We're only drawing blood here, so we're not doing any procedures. We're not using any catheters, needles to pull amniotic fluid or any of those specialized cells. We're just doing a regular blood draw. So this may be a better option for some people. It tests small fragments of DNA that are circulating in the pregnant mom's serum. Unlike most DNA, which is found in the cell's nucleus, these fragments are free floating and not within cells, so we call them cell-free DNA that comes from the placenta. During the pregnancy, the mother's bloodstream contains a mixture of the cell-free DNA that comes from her cells and the cells from the placenta. The DNA in the placental cells is usually identical to the DNA of the fetus, which is why we can use it to detect those abnormalities. And you can do this without harming the fetus, without risk of miscarriage, and without risk of like an amniotic fluid leak. Primarily was developed to screen for trisomy 21, 18, and 13. So for the NIPS testing indication, you might do for a mother of an advanced maternal age. So anybody 35 or older, when you're testing, when you're doing the estimated date of delivery. If the mom has a high risk, maternal screening, abnormality on ultrasound, or previous child with a fetus with an abnormality, this would be recommended. Any of those things at the top would be reasons to move forward with more of the invasive diagnostic testing. So age 35 or older, if their NIPS testing was positive, they have an abnormality on ultrasound, or they have a child, a previous child or a fetus with an abnormality, then these results would indicate invasive prenatal diagnostic testing like CBS or amniocentesis is indicated. Second trimester screenings, around 15 to 22 week gestation, we're gonna do something called a quad screen. The quad screen is a serum measurement of 4 components: alpha-fetoprotein, which measures protein produced by the fetus; unconjugated estriol, or UE3, estrogen produced by both fetus and placenta; HCG, we know it's produced in the placenta; and inhibin A, the protein produced by the placenta and ovary. This quad screen is checking for different things. So risk assessments for open neural defects. In a patient with an open neural tube defect, they may have a high alpha-fetoprotein. In Down syndrome, they may have a low alpha-fetoprotein and estradiol, but a high HCG and an inhibin A. In trisomy 18, they may have a low alpha-fetoprotein, estriol, and HCG. So it kind of gives you the idea, of what you're looking at the second trimester. These tests do not diagnose, they only signal that you need more testing. So I need you to know what the 4 components are of a quad screen. You might want to know that a high alpha-fetoprotein is associated with open neural tube defect. This is the chart with low, high, decrease, very low. I don't want you to memorize this, take it on your rotation with you. But that's the quad screen as well. So alpha-fetoprotein test, the AFP, is a substance made in the yolk sac and liver of the fetus. It is the amount, the amount of alpha-fetoprotein in the blood of a pregnant woman may indicate an increased risk of neural tube defects, which we just talked about, in the baby, such as spina bifida or anencephaly, which is when the brain doesn't develop normally. Alpha-fetoprotein tests can also be done as part of the screening to find chromosomal problems like Down syndrome or Edwards syndrome. Low levels could indicate chromosomal abnormalities. High levels indicate neural tube defects. Just talked about that. Glucose screening. So this is also part of our second trimester test. 24 to 28 weeks, we're going to do a glucose challenge test or a 1-hour glucose tolerance test, which screens for gestational diabetes. The procedure is the patient drinks a syrupy glucose with 50 grams of sugar, and 1 hour later, we measure the blood sugar. The results, if the blood sugar is under 140, that's normal or standard. If the blood sugar is over 140 but less than 190, that indicates they need further testing. If the blood sugar is over 190, it's considered gestational diabetes. So what kind of further testing will we need to do? A 3-hour glucose tolerance test. So if they fail the 1 hour test, then we need to move forward with a 3-hour test. This procedure, they are gonna be fasting with nothing to eat or drink for 8 hours. A fasting blood sugar is drawn. And then they're gonna drink a solution with 100 grams of sugar. They're then gonna test the blood sugar at 1, 2, and 3 hours after consumption. So mom's gonna stay near the lab. You know, she's gonna be testing for several hours that day. If the blood sugar is under 95, that is a normal fasting blood glucose. They drink the sugary syrup. At 1 hour, if it's under 180, that is considered normal. As time progresses, if it's under 155, at 2 hours, normal. At the 3 hour mark, if it's under 140, normal. If just one result is abnormal, you need to repeat this testing 2 to 4 weeks. If 2 or more are abnormal, patient has gestational diabetes. Let's go back. So for the 1 hour glucose tolerance, if it's over 190, it's gestational diabetes. If it's over 140, but under 190, you need to do 4 weeks, the 3 hour glucose tolerance test. And if one of those results is abnormal, you need to retest. If 2 or more is abnormal, you will diagnose that patient with gestational diabetes. We're gonna talk about diabetes again shortly. If high risk, glucose tolerance testing may be done at the first prenatal visit versus the second trimester. Again, we're in the second trimester, but you can do a glucose tolerance test at the first prenatal visit if they're high risk. What is high risk? Their BMI is over 30, if they lack physical activity, have a history of gestational diabetes, if they have metabolic syndrome or PCOS,
God bless you, Sydney Cohen.
if they have diabetes in a blood relative, previous baby weighing more than 9 pounds. Also during the second trimester, we're back to the ROCAM. So this is going to be, again, tested at around 28 weeks. And then we're gonna give that, not tested, but we're gonna give it generally around 28 weeks, and also if there's bleeding or suspected hemorrhage. Moving forward, so now we're going to 29 to 36 weeks. During the prenatal visit, 29 to 36 weeks, mom needs to come every 2 to 3 weeks. Hopefully she's a lot of PTO. Every 2 to 3 weeks, she's gonna have to come to the doctor for a visit. So, at this point, we are still checking fundal height in gestation. At 20 weeks, we are where? Umbilicus. At 36 weeks, we are where? Xiphoid process. We're gonna keep measuring that. We are still pretty reliable at this point. Like we said, 22 to 34 weeks is pretty much a good measure of how many weeks mom is. We're gonna do that method at each prenatal visit. So you're gonna have to get used to that and learn it. I just did site visit 2 OBs in Clinton with 2 students at an OB clinic in Clinton, and they do the every single day, multiple times a day, so you need to learn how to watch the video. All right, amniotic fluid volume assessment. So the amniotic fluid, the normal fetus, we know is surrounded by amniotic fluid. We know that the amniotic fluid serves as buoyancy, stable temperature, protects the fetus from harm, but the baby also drinks it. So it's constantly swallowing amniotic fluid and urinating to create more fluid. The amniotic fluid in pregnancy should be at a certain level. If there's a little or too much, that can indicate issues. So we do something called an amniotic fluid index. And typically we'll test this around 24 or more weeks in a single gestation. It may be different if you have multiple fetuses. The uterus, we divide into 4 quadrants. Each is assessed systemically, so usually they use that linea nigra, cut the uterus into 4 quadrants, and then they do an ultrasound to check each area. So the deepest vertical pocket in each quadrant is measured and added to calculate the total amniotic fluid. So, the normal index is between 5 to 25. Anything less than 5 is considered oligohydramnios or reduced amniotic fluid. And this may be due to decreased urine by the fetal kidneys. It may be due to the fetus receiving inadequate nutrients and oxygen. Or if the amniotic fluid has been ruptured and is possibly leaking. If it's over 25, that may indicate polyhydramnios, which is increased amount. So if the fetus is unable to swallow the typical amount of amniotic fluid, maybe there's some type of gastrointestinal malformation, possibly a mechanical obstruction of the esophagus or some type of neurological problem, or the fetus is just producing too much. Maybe mom has uncontrolled diabetes, elevated sugar, something like that. They may have too much amniotic fluid. A lot of times the etiologies are known of why. So 5 to 25 is the normal fluid index, less than 5, oligohydramnios, then and over 25 polyhydramnios. Each pocket, the deepest single pocket, should be between 2 to 8 centimeters in the entirety of the uterus. So some people use the normal amniotic fluid index of 5 to 25, and then you could possibly use the deepest pocket as well to help. So 2 to 8 centimeters. So if it's less than 2 centimeters, that may mean that it's too little amniotic fluid. If it's over 8 centimeters, that may mean it's polyhydramnios, because sometimes the fetus doesn't cooperate with the ultrasound. So you may not be able to get the total amniotic fluid index. You may just be able to get a single pocket, but you still determine what that level of amniotic fluid is. This is done as part of the biophysical profile, which we'll talk about. This is an old ultrasound sonogram, which you can see they measured quadrant 1 at 3.6 centimeters, quadrant 2 at 3.25, quadrant 3 at 4, quadrant 4 at 3, for a total of 13.97. So is that a normal or abnormal amniotic fluid index? It's 13. Normal, 5 to 25 is a normal index. So they measured from the top to the bottom, that's one quadrant, maybe that one's 3.6, and they did every quadrant they could capture. You can see that online. I'll look at some of those. All right, so non-stress test. A non-stress test, or NST, is performed in the 3rd trimester. It says 28 to 42 weeks. This is gonna provide us with valuable information about the well-being of the fetus. It's non-invasive, there's no stress to the fetus or the mother during this testing. Electronic fetal monitor is applied to the mother's abdomen, and it monitors the fetal heart rate in response to its own movement. So a normal non-stress test result indicates the fetus with adequate oxygenation and an intact central nervous system. Abnormal results could indicate fetal distress or hypoxia. We'll sometimes get non-stress tests if mom can't feel any movement, or she's not feeling it as frequently, or she's gone overdue, she's beyond her due date. If she's at high risk, she has a history of hypertension or diabetes, and there's changes in the baby's growth, we might do non-stress tests. Again, this is a non-invasive test that is not gonna cause any stress to mom or baby. This is a great video I want you to watch before we meet next week, because you're gonna go into non-stress test and contraction stress test in detail. So I want you to watch this short video on your own, before we meet again. The, results for non-stress tests are either reactive, which is reassuring, or non-reactive, which is non-reassuring. You want a reactive stress test. Want it to be reactive. That is a reassuring sign. Reactive stress test is what you're looking for on a non-stress test. A non-reactive stress test doesn't necessarily mean there's a problem, but it does indicate further testing is needed. Possibly a biophysical profile, which we're gonna talk about, or contraction stress test. false positives. So false positive meaning a non-reactive test. You might see in a patient who smokes or if they use certain drugs. So for the reactive, the reassuring side, you need 2 accelerations of the fetal heart rate of equal to or greater than 15 beats per minute, lasting 15 seconds, associated with fetal movement over a 20-minute period. So you need 2 accelerations of the heart rate of 15 beats per minute or more, over 15 seconds or more, associated with a fetal movement over 20 minutes. If they don't meet that criteria, wait 20 minutes and do it again. Again, we're gonna talk about this in detail where you understand it. You can see examples, strips and everything as we get to the last 2 days. Okay, I don't know if we'll get to it Tuesday, but maybe Thursday for sure. It is part of the lecture. We'll just kind of breeze over that for now. We'll go into detail later. The biophysical profile, or the BPC, is completed if there's a non-reactive stress test. So this is our follow-up test. We want a reactive stress test. So when it's non-reactive, you may need to get another test, the BPP profile. Or if there's an increased risk of fetal demise during gestation. You want to do this after 28 weeks. And essentially, it is an ultrasound that assesses the following 4 things over a 30-minute time period: amniotic fluid index, breathing, fetal movements, and fetal muscle tone. Amniotic fluid index, breathing, fetal movements, and fetal muscle tones. They're gonna assess all 4 of those in 30 minutes. Basically, the parameters tell you where the baby is. An 8 is a perfect score. Anything less than or equal to 4 is abnormal. 6 is equivocal. And we do this to test the fetal well-being and identify compromised fetus. So that chart, I don't need you to memorize, but you know what the components are, what they're looking for. To kind of understand that we're trying to see if something's going on with the baby, why they are not reacting on that that non-stress test. The other follow-up test is a contraction stress test, CST. This tests utero-placental function and insufficiency in high-risk pregnancy. It can predict how the baby will do during labor or how the fetus will respond to the stress of contraction. It is believed that fetal oxygenation will transiently worsen by contraction. So, this is performed around 34 weeks. Not used as often as the non-stress test due to contraindications such as labor induction, particularly high with multiples. It should not be used in patients with high risk of preterm labor, preterm membrane rupture, and history of extensive uterine surgery. This is not the best test because you may stimulate more than you need to. How do we do this? What hormone did we say stimulates uterine contraction? So we're gonna give IV oxytocin, then the fetal responds with an electronic fetal monitor. During the contractions, the baby's oxygen and blood supply temporarily drop. Most babies can handle this decrease, but some cannot. If the baby's heart rate stays low after the contraction, they may have problems with typical labor. So we may need to determine what needs to be done differently. Maybe a C-section or something like that. So this is just another backup test if you have a non-reactive stress test. How do we interpret? Negative is what you want. You want a negative CST, where there are no late fetal heart rate deceleration. That means there's good placental function, and the baby should tolerate labor well. There's also a positive finding, which is the abnormal component. If there are late fetal heart rate decelerations, that could indicate compromised placental blood flow, and delivery is usually indicated. equivocal, suspicious, late deceleration to hyperstimulation of the uterus, probably need to test. Unsatisfactory, if you can't get any type of contraction pattern, that's not normally been used either. Can't interpret that, so we would need to retest or do something different. All right, so this is an example of a positive. Do we want positive or negative on CST?
Negative.
We want negative. So this is a positive test. Baseline of the fetal heart rate is around here at 120. You can see that baseline, a dip, baseline dip, baseline dip. Same over here, fetal heart rate baseline of around 120. And then you can see those decelerations. And you'll see repetitive late deceleration with every contraction. The contractions are at the bottom. We're gonna go over the script later. Contractions are at the bottom. And the baby's heart rate is, having a late deceleration. We don't want that. This is another video, great test, great video to watch, about 6 or 7 minutes. Not gonna watch it today, but good for you to review on your own. Let's do results and then we'll take a break. Lastly, before we take our break, we'll talk about repulse maneuver. This, is palpation of a gravid uterus systemically. After 36 weeks, it helps us to determine the baby's position, presentation, and engagement. It also helps us estimate birth weight. So we really think the baby's gonna be about 5 pounds, 7 pounds, 9 pounds, 10. The maneuver consists of 4 distinct actions to determine the position and estimate of the birth weight of a fetus inside the uterus and the shape of the maternal pelvis. It can indicate whether the delivery is gonna be complicated or whether a cesarean section is necessary. So we'll look at those 4 movements. And when you're looking at this, I want you to be very mindful of the hand position. So you can see the mom's, pubic symphysis, the baby's head, top of the uterus, and the hand. And so I'm on the table, my hands are here versus my hands are here, which is what you see on that last picture, picture number 4. Your body, the provider's position is in a different move position from here to here. So just keep that in mind as you look at the maneuver. So for the first maneuver, we're identifying the bundle contents, determining how the infant is situated. So is it hard when you feel it, or is it squishy like a butt? So that tells you the position of where the baby's sitting in there. Second, both hands are gonna go around to check the fetal back. And that helps us determine also the infant's position. The back is smooth. Limbs, fingers, feet, toes are knobby. So the back is smooth, so you can kind of feel where you are. Am I on the baby's back? I'm on the baby's extremities. The back is also the most accurate area for fetal heart monitoring. So if you need to do any further testing, you want to use the back for that. Position 3, hands are now right above the pubic symphysis. Okay? And you want to feel the presentation there. Is it hard like a head, squishy like a butt? That also helps you with engagement. What is the engagement? Engagement tells you where the baby's at. If you can move the head, the baby is not engaged. If you can move it, the baby is not engaged. If you can't move it, you're trying to move the head a little bit and it's stuck. That baby is in position, so it's engaged and deep within the pelvis. And that third position also identifies, like we just said, fetal presentation, breech, cephalic. Fourth position, now you've moved, provider is in a different position. You're gonna identify cephalic prominence and brow. Do you feel the back of the head? Do you feel the brow? You're verifying the degree of fit of the infant's presentation. I'm on the right side of the baby's face, I'm on the back side of the baby's face, I'm on the brow, I'm on the back, so you can kind of determine where your baby's at. So this is all good for positioning, where the baby's situated, is the baby presented in breech or cephalic, and where's the head and the brow. So that's what we usually vote to. All right. We'll go into our last week of testing. Mom's gonna need more PTO. We'll take a 8-minute break. And we will, term does not count as a, it's just a number that is alive at the moment when you do the G.
It's not like.
Currently living, breathing children.
So if your
Got it.
patient's like 70, they still have Gs and Ps, but if their son or something dies, they're no longer living.
Yes. Got it?
Yeah.
Okay. All right, like I said, we're gonna need more PTO because next 7 weeks to birth, you're at the doctor every week. So hopefully you have an understanding employer or somebody to let you stay home. So we are going to look next at Group B strep screen.
And it's less than half an hour a year.
About 25% of pregnant individuals carry Group B
Which is
strep.
I think the best.
This is different than Group A strep, which we learned about in infectious.
They don't know.
Right, so this is not our strep throat, rheumatic, scarlet fever. This is different. All right, in women, it is often found in the vagina and rectum, which means it can be passed to the fetus during labor. This is not common. It affects 1 or 2 babies out of 100 when mom does not receive antibiotics during labor. Group B strep screen can be done, can be found in the urine at the first prenatal visit. The standard of care is to rescreen the mom at 36 to 37 weeks for each pregnancy, unless they have already cultured positive in the current pregnancy or before. If they have a baby and they had Group B strep disease. So unless then, you need to rescreen every 36 to 37 weeks in each pregnancy. Okay. You can do that with a vaginal or rectal swab. Treatment, IV antibiotics during labor, at least 4 hours prior to delivery if possible. The most common treatment is IV PNG. The most common treatment for Group B strep is IV PNG. You may not need it during a C-section.
Mostly.
That will be left to discretion of the physician. The goal is to avoid passing Group B to the baby. If you do a C-section and we know that it's found more in the vagina and the rectum, that kind of bypasses that. There's a little table for you if you want to use that to study. Fundal height and gestation, we're still testing. But now we're at 37 weeks to birth. You'll notice as the pregnancy approaches, the height changes. So at 36 weeks, we were at the zygote process. At 40, we're below that. And we said that's because the baby is starting to go towards the pelvis. It is descending into the pelvis about 2 to 4 weeks before delivery. But those numbers will not be as accurate. That measurement of 22 to 34 is no longer accurate at this point. Next, we're gonna look at fetal well-being. Assessment of fetal well-being leads to better neonatal outcomes. And there are a few different tests that you might do. Serial ultrasounds, non-stress tests, BCT, amniotic fluid measurements, uteroplacental blood flow, amniocentesis, for long maturity. These are different options that you have. As we assess fetal health, mom can help you as well because she can help you identify activity, because she can monitor the baby's movements. Typically, they first start to feel movement around 16 to 25 weeks. If it's a first-time mom, they may not feel those movements until later in the pregnancy. If you've had several babies, you may feel the movements even earlier in the pregnancy, earlier than 16 to 25 weeks. The general rule is in the last trimester. The general rule in the last trimester, 10 movements, kicks, rolls, whatever the baby's in there doing, dancing, in 1 hour or less is normal. 10 movements in 1 hour or less is normal. 10 movements in 1 hour or less is normal, generally in that last trimester. Less activity may mean a sleeping baby. Eating and drinking may cause more activity, especially if you had spicy pad thai or something. Monitoring the baby's movements help identify any changes in activity. So mom will be very helpful in this. This is a baby kit counter tracker. They make keep record of things. So with 10 movements in 1 hour or less is normal in the last trimester. Might also do some fetal activity monitoring. Formal in the office, or you can do it informally at home. This provides information as well about the fetal well-being. Vigorous fetal movement indicates well-being. Decreased fetal movement indicates possible fetal compromise. Lying on the left side may encourage fetal movement, making it easier for pregnant individuals to monitor their movement. So if they're not really feeling anything, you might suggest, okay, well, when you start to feel that decrease in activity, why don't you lay on your left side or eat something and then lay on your left side and see how many you get. If they get 10 kicks in 1 hour or less, that's normal. Other tests, you might do a growth or Doppler ultrasound. If the fundal height doesn't match the gestational age, you might do this. If there's some concern for intrauterine growth restriction, you might do this. And this is when you can do it useful in determining placental flow and health. Just FYI information. So intrauterine growth restriction, which we're gonna talk about again in the next lecture. Pregnancy. Let's see, intrauterine growth describes a pattern of aberrant and reduced fetal growth. The fetus is not reaching its full growth potential based on uterine ultrasound measurements. Historically, it's been defined as an estimated fetal weight less than 10 percentile for fetus gestational age. So that fetus is smaller than 90% of other fetuses at the same gestational age. That's what intrauterine growth is. Fetal weight is less than 10%, less than 10 percentile for the fetus gestational age. Smaller than 90% of other fetuses at the same gestational age. This is growth in utero. This is not the same as small growth, like a small gestational age. This is growth inside the uterus. There are two types, symmetric and asymmetric. You'll see the asterisk next to asymmetric. That is the most common. Asymmetric intrauterine growth restriction is the most common. In the symmetric form, all parts of the fetus are small. The smaller head and body size versus asymmetric, where the head and body size may vary. So maybe they have a big head, small body, or small head, big body. Symmetric usually occurs early in pregnancy, where asymmetric usually occurs later in pregnancy. This can result from a range of different things, some that can originate within the fetus itself, the placenta, or the mother. 40% are never determined. Some 40% we never know why. For symmetric, it could be due to chromosomal abnormalities or torch infections, which you should be very familiar with torch infections. In asymmetric intrauterine growth restriction, it could be due to intrauterine deprivation, diabetes, hypertension, autoimmune disease, placental insufficiency, preeclampsia, poor nutrition. The bottom, you'll see other causes, drug, tobacco, alcohol use, low pre-pregnancy weight or poor weight gain during pregnancy, teratogenic drugs, and multiple gestation. Infants with intrauterine growth restriction may be born small for gestational age. SGA, but many small for gestational age infants may not have experienced intrauterine growth restrictions. Some people are just small because their mom's small and their dad's small. That does not necessarily mean they had intrauterine growth restrictions. And we're gonna talk about this again later. Common complaints of pregnancy. So this is not an exhaustive list. We're just gonna talk about some things in general, problems and how we kind of manage it. The first we'll talk about is nausea and vomiting. Up to 70% of pregnancies are affected by nausea and vomiting. Some have nausea, some have nausea with vomiting, some have nausea without vomiting. The typical onset is before 9 weeks and usually resolves by 14 weeks. That's important because of what we're going to talk about on the next slide. We call it morning sickness, but it can occur any time of the day. Nausea and vomiting is related to HCG levels. Pregnant women often experience fluctuations in their blood sugar levels due to changes in metabolism and hormone levels. When the blood sugar drops, it can trigger nausea. Or it can exacerbate existing feelings of nausea. So we typically recommend some diet changes, like eating small frequent meals or snacks that contain complex carbohydrates to help stabilize those blood sugar levels and hopefully alleviate some of that nausea. So for your treatment, you want to identify the triggers and try to avoid those. You might recommend diet changes. We talked about complex carbs. You might recommend dry toast and crackers before getting up, protein after bed or before bed. If your stomach say food, small frequent meals, keep the blood sugar from dropping, drink between meals to avoid overfilling the stomach. Some patients might need to change to an iron-free prenatal vitamin. And then there is vitamin B6, Unison, which is over the counter. Then we have our prescriptions for promethazine, ondansetron, and then diphenhydramine can be used. All right, hyperemesis gravidarum. So this is why we said the timeline is important, because we said most of these improve or resolve after about 14 weeks. And hyperemesis gravidarum, this is severe. This is the severe end of the spectrum. So these patients have persistent nausea and vomiting, and it's constant. This is not like morning sickness that subsides after a couple of weeks. This is intractable vomiting. These patients often lose weight exceeding 5% of their pre-pregnancy weight. They cannot keep anything down. Severe symptoms may lead to malnutrition, dehydration, and disability. Symptoms can negatively impact their daily functioning. It can cause anxiety and depression, make people not want to have any other children ever. Again, you never want to be pregnant again. Area. Treatment for this, supportive care. Everybody's different, so they're gonna respond differently, but some patients might need IV fluids, hospitalization. There are prescription medications. Just talked about a few of those. The woman is constantly vomiting. She's got intractable vomiting. Do you think oral medication is helpful? Or would it be effective? Maybe not. Might not be able to keep anything down. So you might need to think of other methods, patches, sub-Q, IV routes. Some women are at a risk of thiamine deficiency due to persistent vomiting. Thiamine plays a crucial role in energy metabolism, particularly carbohydrate metabolism, and that deficiency can lead to Wernicke's encephalopathy. So they may need thiamine as well as some of those RX medications, promethazine, diphenhydramine, ondansetron, Breadwin, steroids, diamonds, Vibrance. Yeah. The royal family there because she did suffer from that as well with her pregnancy. She's a trooper, she kept having. All right, this is a resource just for different medications. Take this on your rotation with you. Moving forward. Urinary frequency, this is a problem. This is usually related to bladder, pressure on the bladder, vascular engorgement, and hormonal changes. Big baby hanging on top of your bladder might cause decreased bladder capacity. You can't hold it as much. You gotta go, gotta go, gotta go. So for treatment, of course, the patient just needs to void as needed. Drink fluids throughout the day, limit them in the evening. And make sure they understand the signs and symptoms of UTI so that they can report to you promptly for treatment if needed. Fatigue. I am tired. So this cause of fatigue is poorly understood. They believe it's related to pregnancy hormones. It may have a protective effect during the critical period of embryonic development due to its potential role in reducing physical exertion and stress on the mother's body. Treatment, nap is needed. I need a prescription for that. Eat a healthy diet. Take prenatal vitamins. Energy levels typically improve during the second trimester, then fall again in the third trimester. So just make your patient aware of that because they may complain. I was feeling so much better, you know. Breast tenderness, we talked about this earlier. This is related to the effects of pregnancy hormones and increased blood flow. Treatment, you want to wear a well-fitted supportive bra. You may need resizing during pregnancy as the breasts grow, and again for lactation. Leukorrhea. This is related to the effects of estrogen likely that increase throughout the pregnancy. This is of course a vaginal discharge that are secreted. They are responsible for lubrication and prevention of infection. It increases the acidity of the vaginal secretions, decreases the chance of most infections, but it's more favorable for growth of candida. So you want to recommend good daily hygiene, wear cotton underpants or undergarments, wear and change of pad or panty liner if needed. Report signs and symptoms of a yeast infection. So they need to be aware of what are the signs and symptoms of a yeast infection so they can know what the difference is. Heartburn. This is related to the effects of progesterone. We talked about progesterone relaxing that smooth muscle everywhere, not just the uterus. So it can also relax the cardiac sphincter muscle. Causing regurgitation of the contents of the stomach into the esophagus. They need to eat small frequent meals. Drink fluids between meals. Remain upright 30 to 60 minutes after a meal. Certain antacids may be suggested, H2 blockers and PPIs. Some classic triggers, caffeine, chocolate, citrus, tomatoes, mustard, vinegar, mints, highly seasoned, fried and fatty foods. So you want to just educate them about their diet. Syncope. This is related to the inferior vena cava syndrome or supine hypotensive syndrome. So in pregnant women, the enlarged uterus can compress the inferior vena cava, particularly when the patient is lying supine. This can cause lightheadedness, dizziness, syncope, due to reduced blood return to the heart. The rule of thumb is if the patient begins to feel dizzy, sweaty, or nauseous anytime while they're laying on their back, they need to turn to their left side. So anytime your patient is complaining, oh, every time I lay on my back, I feel so sweaty, I feel short of breath, I'm nauseous, I'm dizzy, they need to turn on their left side. They also encourage them to sleep on their left side. If possible.
No, by the left.
So. So you can see, like, if you have the wedge there, if the inferior vena cava is on the wedge versus being compressed on the other side, it doesn't get smashed as much by the weight of the uterus. Other common complaints, edema, with water retention, swelling, is due to increased intravascular fluids, constipation. We talked about that smooth muscle, the progesterone, smoothing out everything. And it's also making your stomach, digest food a little bit slower. And bowel transit time is reduced, mild low back pain, postural changes during pregnancy. You can see the different back curvatures as the weeks progress. Acid indigestion, back pain, swelling through headache, vicious stool. Resource there. And then lastly, we're going to talk about food cravings and pica. Some of the top food cravings: chocolate, candy, pizza and chips. I might be pregnant. Steak, fruit, cheese and sour cream, breadsticks and cereal, fast food like Chinese or vegetables, ice pops and slushies, vegetables, ice cream and milkshakes. Those are some of the common cravings.
Just a really,
And then the other end of the spectrum are the cravings that are not
a lot of the salt.
like clay, cigarette ashes, burnt matches,
Cigarette ash,
starch, paper.
you're kidding.
I have a list here that. Like, common substances craved during pregnancy. The most common are dirt, clay, and laundry starch. Other cravings include burnt matches,
Yeah.
charcoal, mothballs, ice, cornstarch,
I can get that abnormal.
soap, sand, coffee
What
grind,
about that? Yeah.
baking soda, and cigarette ashes.
You be eating your toothpaste?
They should not be able to.
At least get
Which
the
is great.
pediatric kind that you can swallow.
So it's really important.
Yeah,
to
that
get a
stuff
good
actually is not
history,
bad.
Talk to your patient, build that trust, build that patient rapport, because you need them to be open with you about these things. Hey, are you having any cravings? You know, even
Eating
anything
cigarette
unusual, and try to get them to open up to you so that you can address it. As needed.
Bruh.
Okay.
That's not.
All right, final thoughts. So I want you to be able to go over these. We're not answering them right now, but when to give Rogaine? What strategies can you use for feeding those? What can you use for maternal health? What can you use to identify potential pregnancy and delivery complications? What's the difference between CBS and amniocentesis? What amniotic location should the fungal height be at 20 and 36 weeks gestation? What is measured in the fly screen? What does GTPAL mean? Common complaints of pregnancy and patient education for each. What's the purpose of prenatal visiting counseling? Why is Lee Pulse maneuver performed? Any questions?
Oh.
He has none. He just wants to know why his mom's eating so. I did leave a resource at the bottom, 21 foods to eat when pregnant, things that they suggest through the Pampers organization, and some common swaps that you can do for healthier, because remember, we only want to eat so many extra calories per day, so we need to have a good idea on what we want to educate our patients about in terms of swapping out some of that chocolate for maybe dark chocolate, fast food for maybe cooking and whatnot, healthier options. So that's just a resource for you. And then we will move forward. So we're gonna go into pregnancy complications. Any questions about prenatal care? All right. So pregnancy complications, although most pregnancies are uncomplicated, sometimes unplanned events happen. So we're gonna talk about some of the complications, and some of those we're going to discuss today are bleeding, ectopic pregnancy, preeclampsia, threatening abortion, miscarriages, and whatnot. Placental previa, placental abruption. We'll start with ectopic pregnancy. So this, picture should be familiar to you. Just look at some of the anatomy. Fertilized, ectopic pregnancy is when a fertilized ovum implants in an area outside of the uterine cavity. When a pregnancy occurs outside of the uterine cavity, that's what an ectopic pregnancy is. The most common site for implantation is the fallopian tube. The most common site for implantation in an ectopic pregnancy is in the fallopian tube. And where do we say fertilization occurs more often?
Ambula.
Ambula. So the ambula is the most common area for a tubal pregnancy or an ectopic pregnancy.
Bless you.
For some patients, that little blastocyst just never makes it down to the uterus. It just implants right there in the fallopian tube and starts to develop. This happens in 1 in 50 pregnancies, or about 2% of pregnancies. These are non-viable. These are non-viable. You cannot take this and move it into the uterus. Implantation can occur outside of the fallopian tube. Some other areas, the abdomen, the intestines, cervix, ovary, and a previous cesarean scar. It can implant other places, but the most common is the fallopian tube. The incidence of implantation in unusual sites has increased with assisted reproductive technology, or ART. Very rarely, a patient can have both an intrauterine and an extrauterine pregnancy at the same time. This is called a heterotopic pregnancy. So they have one in the fallopian tube and they have a regular one in the uterus. The one in the fallopian tube is gonna have to go. So the patient will have to have surgery, but that's not very common. So don't worry about that. Just be aware of it. As we said, an ectopic pregnancy is not viable. It cannot develop normally. And it could be life-threatening for the pregnant individual. A ruptured ectopic pregnancy can result in significant bleeding, as blood vessels are disrupted, leading to internal hemorrhage. Life-threatening hemorrhage, especially without prompt medical intervention. It is a leading cause of maternal death in the first trimester. Ectopic pregnancy is a leading cause of maternal death during the first trimester. In theory, anything that hampers or delays the migration of the fertilized egg can predispose a woman to ectopic gestation. Some risk factors are history of ectopic pregnancy. Recurrence rates are about 30%, so if you've already had one, it's a 30% chance you'll have another. Pelvic inflammatory disease, anything that causes inflammation in the tube can put you at risk for a tubal pregnancy. We just talked about assisted reproductive therapy or technology, in vitro. Contraception failure in patients using IUDs or sterilization methods can cause an increased risk, as well as a smoking history. Advanced maternal age, multiple sex partners, all of those can put you at risk. So what do we see? Signs and symptoms. At first, an ectopic pregnancy may feel like a normal pregnancy. Typical, same signs, symptoms, positive home pregnancy test, missed periods, tender breasts, kind of your normal nausea, upset stomach. But then some of the warning signs that may be a little bit different. First being pain, pelvic or abdominal pain, unilateral cramping. Pelvic pain and abdominal pain is present in almost 100% of cases. Some patients may complain of low back pain as well. If a patient has shoulder pain or subdiaphragmatic pain, this might suggest intra-abdominal bleeding. Abnormal uterine bleeding, usually spotting, a major hemorrhage is less common. About 75% of cases have some type of abnormal uterine bleeding. Could be light intermittent spotting, could be heavier. Amenorrhea, missed periods. This can be variable, as some experience a sudden and complete absence of periods, while others have spotting instead of a normal menstrual cycle. Approximately half of women with ectopic pregnancies have bleeding at the time of their expected menses and may not even realize they're pregnant. Some patients will complain of abdominal tenderness, adnexal mass, or fullness might be felt. And then we're gonna talk about this, we just talked about at the top, symptoms of rupture and intra-abdominal bleeding. Sudden and severe pain, this is different, this is the sudden and severe pain. Shoulder pain, they're passing out, syncope, hypertension, tachycardia, pallor, peritoneal signs.
God bless you, Cynthia.
These are signs of bleeding.
We should get you a book.
Approximately 20% of patients with ectopic pregnancies are hemodynamically compromised at initial presentation, so they're in trouble. How do we make the diagnosis? Any pregnant patient presenting with vaginal bleeding and or abdominal pain has to be evaluated. Any pregnant patient with vaginal bleeding and or abdominal pain has to be evaluated. We're doing a pelvic exam, we're assessing the size of the uterus, we're examining the cervical os, we're looking for bleeding. You want to be very careful. You give too much pressure, you're heavy-handed, you're too aggressive, you can make the problem worse. So you want to be very gentle. The uterus could be normal size, it might be enlarged. We are going to also do a quantitative serum HCG. We said HCG doubles. First 30 days, every 2.2 days. If that HCG is low or stable and not increasing, then we need to be concerned about an ectopic pregnancy. May do a CBC, hematocrit to assess for hemodynamic status and the amount of intra-abdominal bleeding. Transvaginal ultrasound is going to be the most useful imaging test for determining the location of the pregnancy. Is it in the uterus or outside of the uterus? Do you have an empty uterus? Visualization of an extrauterine gestational sac with yolk sac or embryo, with or without a heartbeat. Free fluid or blood in the pelvic cul-de-sac are also telltale signs. This is a heterotopic pregnancy on the picture. So they've got an intrauterine gestation and they have an ectopic gestation at the same time. The ectopic one doesn't have to go. All right, so here's a picture, uterus, a tubal ectopic pregnancy. In rare cases, ectopic pregnancies might resolve without intervention. Especially if it's detected early, but this is uncommon. This is very uncommon. Because they can be life-threatening, patients should be treated as quickly as possible with either medication or surgery. Surgery was once the mainstay, but now mainly it's reserved for patients with contraindications to medical management, and medical management is methotrexate. Methotrexate comes in several doses, but a single dose intramuscular injection is the most popular. Methotrexate stops the cells from growing and ends the pregnancy. Pregnancy is then reabsorbed by the body over the next 4 to 6 weeks. If for some reason patient fails therapy, or they can't take the methotrexate, or they're hemodynamically unstable, then we need to look at laparoscopy, exploratory laparotomy to assess the bleeding site, or some type of surgery to remove the ectopic pregnancy. If there's damage to the fallopian tube, salpingectomy is recommended. Complications, tubal rupture and intra-abdominal hemorrhage, tubal rupture into the peritoneal cavity causing peritonitis. The prognosis, about 60% of these patients can get pregnant again. About 30% of them will have subsequent ectopic pregnancies. So we're treating with either methotrexate or surgery. Methotrexate or surgery. The patient is hemodynamically unstable. If I give you a scenario and the patient is hemodynamically unstable, you have options. You need to treat the surgery. Remember, this is a life-threatening condition possible. So differential. If a patient has severe pain, or if they have abdominal pain, if they have bleeding, if they have these similar symptoms, what are some other diagnoses we can think about? Ovarian torsion, yes. What else? We talked about one that puts you at risk for ectopic pregnancy that might be due to inflammation. GID. What else?
Endometriosis.
Endometriosis,
Appendicitis.
appendicitis, what did you say?
It was on the right side.
Appendicitis,
Kidney stones.
ovarian cyst ruptures, spontaneous abortion is one, which we will talk about next. So these are some other things you can be thinking about in your differential. But any pregnant patient with vaginal bleeding and or abdominal pain needs to be evaluated. So we're gonna talk about abortion next. Abortion is a word that is very controversial in social settings. In the medical world, it is a medical term. It is a medical term. This is what we'll use, miscarriage, abortion. It is a medical term for this setting. It is often used to describe natural or induced termination of a pregnancy before the fetus is able to survive outside of the uterus. This is a discussion you will have to have with your patient as well. We're gonna talk about some different types of spontaneous abortions. Threatened, inevitable, incomplete, complete, and missed. The most common complication of early pregnancy is spontaneous abortion. The most common complication of an early pregnancy is a spontaneous abortion. Delivery of a non-viable intrauterine pregnancy before the 20th week of gestation of any or all products of conception. Typically, the fetus weighs less than 500 grams. At this weight, it's usually around 16 weeks of pregnancy or earlier, the fetus usually has not developed the organs and systems it needs to live. So we're gonna talk about these in a linear order, and I'm gonna skip forward and then come back. So this was a mnemonic that I found on YouTube that truly helped me. When I was in PA school, we just learned them individually. Threatened abortion, this abortion, it's inevitable, complete. But this helps you think of it in a way that makes more sense and it's easier to memorize. So I would certainly use those 7 minutes and listen to it because it is very helpful in terms of thinking about the order of these abortions. From threatened, it will either go to a missed abortion or the abortion. And then inevitable, incomplete, and complete in that order. So we'll go back and look at them. I put them in the order there. So the first one, the threatened abortion. This is any vaginal bleeding before 20 weeks. Any uterine bleeding before 20 weeks is considered a threatened abortion. Here, there may be or may not be uterine cramping. The cervical os is closed and there's fetal cardiac activity present. Everything is intact. There's no rupture of membranes. There's no products of conception that are out of the body. Everything is intact and where it's supposed to be. This is still viable and can progress to a healthy pregnancy. Threatened abortion. It's vaginal bleeding before 20 weeks. Can still progress to a healthy baby. If the bleeding and the cramping resolve on their own, that is usually favorable for a good prognosis. So that's threatened. That's any uterine bleeding before 20 weeks. Threatened can progress to mist. So TM Inc., trademark Inc. Remember that mnemonic, TM Inc. So the T, the threatened, can either progress to the M, the mist, or it can progress to the Inc. So mist, there's no vaginal bleeding. The os is still closed. So remember, we started with the os closed in the threatened, the os is still closed in the mist. There is no fetal cardiac activity, however. No fetal cardiac activity. Unfortunately, there is a fetal death in utero. But the baby is still in the uterus. No expulsion of products of conception. There may or may not be symptoms. They call it mist or silent, so you may not even know. There may not be symptoms. Hmm,
All of these are before 20.
yes, all of these are before 20. Threatened abortions can progress to incorporated, the INC, inevitable, incomplete, complete. The OS for inevitable is open, but products of conception are still there. Bleeding may be present with back or abdominal pain. So we had threatened, os is closed, everything where it's supposed to be, can still be a viable, healthy pregnancy. Either gonna go to mist, os is closed, but the baby is still in there, no fetal cardiac activity. If it doesn't go to mist, then it goes to the Inc. Inevitable is the first one. With this one, the os is now open, it's dilated. Patient has bleeding, patient has cramping. But everything is where it's supposed to be. It's still in there, nothing's come out. Moving to the next step. So if nothing came out, for the next step, a little bit came out. So incomplete, passage of some products of conception. You might see tissues on the exam. Bleeding and cramping usually continue until all products have been passed. These patients may have severe pain, heavy bleeding that causes them to seek medical care. So threatened, closed, mist, closed, baby still in there, it's gonna have to be removed, it's fetal death. Inevitable, it's open now, but everything's in there. Incomplete, it's open, but some of the products of conception are starting to come out. For complete, everything came out, and now the cervix is starting to close back up. So close, close, open, open, closing. Everything is out in the complete. It is complete. Everything is over. It is done. The uterus is firm. Some patients may have slight bleeding and malcramping still for a couple of weeks. That video for the TM Inc. will help you see this. It is very, very helpful. I wish I would have learned it. I couldn't see it. Guaranteed pants question. The other two I want you to be familiar with that are not part of the trademark incorporated are recurrent and septic. Recurrent, 3 successive spontaneous abortions, and septic, which is fetal demise, intrauterine infection has started to develop, so it's a septic abortion. It is causing an infection in the mom. Symptoms might include abdominal or pelvic pain, uterine tenderness, vaginal discharge that is purulent, elevated white blood cell count. When not treated urgently, septic abortions can progress and be lethal. These patients need high dose antibiotics and surgical evacuation.
Is the baby septic and that affects the mother, or the mother becomes septic and that affects the fetus?
So the baby is deceased.
Okay,
and now an infection has occurred from that deceased fetus.
thank you.
All right, there's your YouTube. It is a clickable link, I believe. Spontaneous abortion, signs and symptoms and diagnosis. Signs and symptoms vary depending on the classification of the spontaneous abortion. That's a little chart you can use. I believe that's from osmosis, I'm not for sure. 3 key indicators for diagnosis: pelvic exam, serum HCG, and an ultrasound. The essentials of diagnosis. We know there may be suprapubic pain, intrauterine cramping or back pain. There may be vaginal bleeding. There may or may not be cervical dilation. There may or may not be passage of products of conception. Signs and symptoms of the pregnancy may diminish or disappear. So all the nausea, the breast tenderness, the fatigue, all these things start to improve in some of these patients. That can be a sign. A negative pregnancy test. Now, I got a negative pregnancy test. I had a positive pregnancy test, but now I have a negative, which means that qualitative, HCG is probably down below 25. The HCG is unchanged, it's decreasing or not appropriately increasing. And then abnormal ultrasound, extrauterine pregnancy on ultrasound. Management and treatment. Abortion likely to occur if the cervix is dilating. If that cervix is opened, the likelihood of abortion is increased. No fetal heartbeat, decline in HCG with bleeding. Those are not good signs. Management, expected management. This allows the spontaneous passage of products of conception or expulsion of fetal tissue from the uterus and avoids the risk of surgery. This is usually limited to gestations within the first trimester. The risk and side effects include unpredictable timing until the abortion is complete, with the possibility of significant pain and bleeding. These patients may require emergent D&C. So that is only something you would do in the early pregnancy, is that watchful waiting. Yes, Brian.
So forgive my ignorance, but if this is like a timeline or are
With-
these like, I'm asking about previous slides. So inevitable, incomplete, complete, how do you know that it hasn't? It's not like waiting for that slide, it's, the cervix is dilated, the os is open, the vaginal bleeding, how do you know that it's not eventually going to surpass the?
Like if it's, like, let's say inevitable, how do you know it's not gonna go to like the incomplete? Like with the with the
Yeah, or
conception?
the,
Okay.
eventually.
It could. Yeah,
So it's just whenever you're specifically grading it.
when you're grading, what are you seeing at that time of the exam? Are you seeing tissues in the vaginal vault? That is probably passage of conception. Is the os now open or closed? This is helping you determine where am I in this abortion.
Okay, perfect. Thank you.
Expected management also has the highest rates for retained pregnancy tissue, which also is gonna need further treatment because those products of conception will eventually cause some infection in there. DNC, dilation and curettage, medical management. You also need to identify their RH status. Do they need ROGAM? They are RH negative. Do they need ROGAM? Or is it RH positive? Negative. All right, if it's a threatened abortion, some patients may be recommended pelvic rest, bed rest, pelvic rest, no sex. Resolving symptoms indicate a better prognosis, but some still end up requiring DNC. DNC is a procedure to remove tissue from the uterus. You can see the instrument in there scraping the lining. Risk and complications include perforation of the uterus, damage to the cervix, scar tissue formation on the uterine wall, and infection. If we don't do a DNC, you may have the option of a medical abortion. This option is if the patient wants to avoid a DNC or they do not want to do watchful waiting with expected management. It is a 2-drug protocol with mifepristone followed by misoprostol. That combination has shown improved efficacy compared to misoprostol alone. The mifepristone blocks the action of progesterone, and as we recall, progesterone helps us do what to the lining?
It is.
So keep it thick, it helps maintain the pregnancy. So if we block progesterone, then we're gonna thin that lining and break it down. Eventually, the embryo and the fetus is gonna detach. Mifepristone also increases the sensitivity of the uterine lining to the effects of misoprostol, which stimulates prostaglandin E1. That promotes cervical softening and dilation and causes uterine contractions, which help expel those contents out of the uterus. Some of the complications of medical management or medical abortion are retained products of conception, which makes you have an increased risk of infection, possible hemorrhage, and rarely death.
Bless you.
You will need to educate your patients if they have to get a medical abortion, that you are going to induce uterine cramps. You are going to induce vaginal bleeding. You are going to make them nauseous and vomit possibly. They're gonna have headaches, diarrhea, fevers, chills. It is not a good feeling. They need to be educated in what's happening, what's going to happen. They will need to follow up in 4 to 14 days to ensure that the abortion is complete and all products of conception are eliminated. And we're gonna do that with transvaginal ultrasound. We also wanna check the HCG to make sure it's rapidly declining and there's nothing left in there, uterus, that will keep those numbers going. Warning signs for a medical abortion and spontaneous abortions in general: fever over 100, severe or persistent abdominal pain, cramps or backache, prolonged or heavy bleeding of more than 2 soap pads per hour times 2 hours. Prolonged bleeding or heavy bleeding of more than 2 soap pads per hour times 2 hours. 2 soap pads per hour times 2 hours. Two soap pads per hour times 2 hours. A foul vaginal discharge, foul smelling vaginal discharge. Not a good sign. Possible infection. Chills, increased heart rate, malaise, or other systemic signs and symptoms. You should also be concerned if their period does not come back. If it is delayed 6 or more weeks. There may be products of conception. There may be something else going on that needs to be evaluated. That is a warning sign. So when you see them back, you'll see them initially at that 4 to 14 days, do your transvaginal, check the HCG, and they're gonna need to come back again. If your period does not come back within 6 weeks, I need to see you back for a follow-up, or go ahead and make the follow-up and try to keep that consistency going with the appointment. Okay? Next, we'll talk about placental issues, endometriosis and placental eruption. We'll start this after the pregnant day question.
But this on that last slide, said the fever, the chills, on the warning signs, but also something to educate the patient about. Is there like a line where it's needed?
No. Just, be aware of it. Yeah, just, I would just be aware if their fever's over 100, yes, but you may feel warmer to letting you know how much fever you feel, that kind of thing. But if your fever goes over 100, let me know, is what I would say. Any other symptoms? Now you have a fast heart rate.
To catch it today.
That was really interesting. You're gonna be here all night. Okay, placental and placental abruption. So we're gonna talk about the placental issues. So we see the placenta, this cute little baby. We know the placenta is like a pancake-shaped organ attached to the wall of the uterus that connects the fetus by the umbilical cord. It produces pregnancy-related hormones, HCG, estrogen, and progesterone. Through the umbilical cord, the placenta provides oxygen and nutrients to the developing baby. It also removes waste from the baby's blood. The placenta is expelled from the uterus in a process called the afterbirth. We will discuss two possible complications, placenta previa and placental abruption, or placental abruption, or whatever they call it. All right, so placenta previa. Most often the placenta attaches to the top, side, front, or back of the uterus. In placenta previa, the tissue is implanted in the lower segment of the uterus and over the internal cervical eye. So it's not where it's supposed to be. And we'll see a picture of that in the next slide. When this happens, it may block the cervix partially or completely. This is the leading cause of third trimester bleeding, but can occur earlier in pregnancy. There are three types: complete, which covers the cervix completely; partial, which partially covers the cervix; and marginal, which is near the edge of the cervix. Signs and symptoms of placenta previa: pain less, bright red bleeding. Pain less, bright red bleeding. Pain less, bright red bleeding. Placenta previa. Risk factors are same ones we had before: advanced maternal age, smokers, multiple gestation pregnancy. If you've had a history of placenta previa in the past, these put you at risk. How do we make the diagnosis? It is suspected in any patient over 20 weeks gestation with vaginal bleeding. So our spontaneous abortions were before 20 weeks. Our placenta previa is after 20 weeks. Abortions, spontaneous, threatened, missed, inevitable, incomplete, complete, before 20 weeks. Placenta previa, third trimester, after 20 weeks. Any patient with any patient with bleeding after 20 weeks, you need to be thinking about placenta previa. You want to confirm this with ultrasound. It's going to show you where the placenta is sitting. You want to avoid. Do not use your finger to do a digital exam. You may cause bleeding. Avoid digital exams in these patients. Placenta previa, here are the pictures. The normal placenta at the top of the uterus, marginal, near the edge, partial, partially covering the internal os, and total, completely covering the internal os. The goal in management of these patients is to protect the placenta, the mother, and the fetus until the baby is fully mature. If bleeding is excessive, a cesarean despite age of the baby. Cesarean regardless of gestational age. If the bleeding is excessive, you have to deliver the baby now, whether or not you think it'll survive or not. If the bleeding is manageable, it's not profuse, it's not repetitive, then those patients may respond well to absolute bed rest, meaning they're only getting up to use the restroom. And some patients will require hospitalization for this. You want to give them stool softeners. Why? Do you want them pressing if they're constipated? No, we don't want any type of extra pressure down there. They may need vitamins, they may need steroids. If the patient is able to reach 36 weeks, you need to determine if fetal lung maturation, where it's at before you do a C-section, and you can do that with amniocentesis. So those babies are more likely gonna have to come out. If the baby's less than 34 weeks, they need steroids so that their lungs can hopefully mature enough once they're born. All right, so that's previa. Painless, bright red bleeding. Any bleeding after 20 weeks, you need to be concerned about placenta previa. Placental abruption or abruptio placentae. This is where there's a premature separation of the normally implanted placenta from the uterine wall. So it detaches itself from the uterine wall after 20 weeks, but prior to the delivery of the fetus, because we know that the placenta is going to detach and come out in afterbirth, but we don't want that before the baby is born. So this affects about 10 out of 1,000 births, and abruptions end in fetal demise in 1 out of 830. The primary cause is unknown in most cases, but it is linked to several risk factors: maternal hypertension, previous abruptio, trauma, polyhydramnios, that rapidly decompresses. And how do we test polyhydramnios? Amniotic fluid index, 5 to 25. The premature rupture of membranes is from short umbilical cord, tobacco and cocaine use. Cocaine use. Folate deficiency. Signs and symptoms, vaginal hemorrhage and abdominal pain. When I think of abruption, I think of abrupt, something quick. Think of something like that hurt. Abruption, pain. Previa, painless. Abruption, abruptly hurts me. It hurts, painful. Abrupt, abdominal pain, whatever you need to memorize it. Increased uterine tone can result in a hard, rigid, and tender uterus. Hypercontractility. These patients may have severe abdomen, pelvic, or back pain, and occasionally vaginal bleeding that may not be present if it's concealed, where the blood is trapped behind the placenta and cannot escape. Placental abruptions will present with the clinical triad of fetal distress or death, tetanic uterine activity or contractions, and or uterine bleeding, external or concealed. That little clinical note there at the bottom, those three, usually how it presents, but patients may not have all three. Fetal distress is typically the first clinical sign among patients who have continuous fetal monitoring during the abruption. Placental abruption management should be prompt intervention and treatment. You want to secure IV access, place one wide bore IV needle. Place two if the patient has signs of moderate or severe abruption, such as moderate heavy bleeding, hypotension, abnormal fetal heart rate pattern. You want to monitor the fetal heart rate continuously. You want to obtain CBC, PT, PTT, platelets, fibrinogen, type and cross-match the blood. Monitor heart rate and blood pressure. These patients may need induction, hospitalization, C-section. They are eligible still for vaginal delivery. Some of the complications might be severe hypovolemia and shock, which could then lead to some acute renal failure, or if they work intertwined. Disseminated intravascular coagulation, DIC, is also another complication. Hypertensive disorders of pregnancy. Any questions on placenta previa, placenta abruption? Abrupt, painful, bleeding, previa, painless, bright red. All right, so hypertension, several different categories. We're going to talk about these: chronic, gestational, preeclampsia, eclampsia, chronic hypertension with superimposed preeclampsia. For chronic hypertension, these are patients with known hypertension. They have high blood pressure. They've had it before they were pregnant, or they were diagnosed prior to 20 weeks of pregnancy. There's an increased risk of preeclampsia later in pregnancy in these patients. Gestational hypertension or pregnancy-induced hypertension, PIH. This is a new onset hypertension without protein in the urine after 20 weeks of gestation. No other signs of preeclampsia, which we're going to talk about next, and it resolves after delivery. Those patients are at increased risk of developing hypertension in the future. Preeclampsia and eclampsia. This is a new onset hypertension and proteinuria. If there's no proteinuria, they have thrombocytopenia, they have renal insufficiency, they have impaired liver function, pulmonary edema, cerebral or visual symptoms, right upper quadrant pain. We're going to talk about that all in detail. In eclampsia, they have preeclampsia, but they now have new onset tonic-clonic seizures. So that's the difference. Seizures that cannot be explained otherwise in a patient with new onset hypertension and proteinuria is preeclampsia. And then chronic hypertension with superimposed preeclampsia is patients that have the pre-existing hypertension with a new onset of protein in the urine. So we'll talk about those separately. Let's just quickly, new onset criteria. If their systolic BP is greater than or equal to 140, or their diastolic BP is greater than or equal to 90 millimeters of mercury, that is considered hypertension. How to take the blood pressure, and then the levels of protein. Proteinuria is considered 0.3 equal to or greater than 0.3 of protein in the 24-hour urine, or 0.3 in the protein creatinine ratio. This correlates with the 1+ on the urine dipstick in a random collection. So that's just your criteria to know moving forward, what we're looking for. This is a great chart you can use to help study, has more details than the one before, with each different subset of hypertensive conditions, complications, for hypertension in the mom, placental abruption, DIC, renal failure, hepatic failure, CNS hemorrhage, and stroke. These are all possibilities of hypertension in pregnancy in the mom. In the baby, intrauterine growth restriction, which we talked about earlier, prematurity and perinatal death, which is the period from the 22nd week of gestation through the first 7 days after birth. This includes stillbirths. There's a higher chance for that in babies who are born to hypertensive moms. So definitely look over that chart. Preeclampsia, also known as toxemia of pregnancy. It is a condition that only occurs in pregnancy and is characterized by new onset of hypertension plus significant in-organ damage dysfunction with or without proteinuria in a previously normal tensive patient, typically after 20 weeks of gestation or postpartum. Exact cause is unknown. It is a leading cause of maternal mortality in the U.S., leading cause of maternal mortality in the U.S. Oh, that's a repeat, sorry about that. All right. Let's see, diagnosis is based on 2 criteria: elevated maternal blood pressure, greater than or equal to 140 millimeters of mercury systolic, or greater than or equal to 90. On 2 occasions, 4 hours apart. On 2 occasions, 4 hours apart. On 2 occasions, 4 hours apart. Other signs might be we talked about the protein, thrombocytopenia, or platelets, renal insufficiency, impaired liver function, pulmonary edema, cerebral or visual signs and symptoms, pain in the epigastrium or right upper quadrant. We'll talk about those. More common in birth pregnancies. I have 2 friends that both delivered babies after 40, one in January, one in February, both had postpartum preeclampsia. One was on her 2nd pregnancy, the first was the first time. Risk factors: advanced maternal age, over 40 years old, so both of them knocked off that figure. Multiple gestation, family history of preeclampsia, past medical history of diabetes, migraine, kidney disease, BMI classifications of obesity prior to pregnancy. If a patient presents with the same symptoms prior to 20 weeks, the ultrasound needs to rule out a choriocarcinoma or molar pregnancy. Choriocarcinoma we talked about, that's that cancer that develops, or molar pregnancy. Which we'll talk about later. That's a tumor in the uterus. It is non-viable. Just another reminder, not going over that, we've already done that. These are just resources. Some of the older texts have different times, so you'll see here it talks about every 6 hours, and the previous slide it said every 4 hours. Just know that there are 2 new classifications for preeclampsia. It used to be mild and severe. Now it is preeclampsia with severe features and preeclampsia without severe features and preeclampsia with severe features. So that's how they break it down now. I'm not so caught up on that hour, at least 6 hours, not for this classification. And those are the signs and symptoms that patients may have with severe features. Another resource. What are the signs and symptoms? Abnormal weight gain or edema. Visual symptoms, they may have blurred vision, flashing lights. Scotomato, which is like a partial blindness, like they're, not able to see they have a blind spot. Visual, new onset and persistent headache. This is something I go over in my family medicine breakout for the second years. New headache in a pregnant patient, new headache in a pregnant patient needs to be further evaluated. New headache in a pregnant patient. Epigastric right upper quadrant pain from liver hemorrhage or infarctions. They may have increased liver enzymes. New dyspnea, shortness of breath, amygdala flat, vasospasm of the placenta. Nausea, vomiting, brisk patellar reflexes and clonus on exam. They may have hyperreflexia. Management considerations, if it is, that's an old one, I should have redone it. If it's preeclampsia without severe symptoms or with severe symptoms, that's what you need to consider. Is there fetal compromise? Is the fetus mature enough for delivery? Based on gestational age and maturity, these are things you should be thinking about. In management, delivery is the only definitive cure. Delivery is the only definitive cure. Patient must be stabilized prior to the delivery. You want to make sure you do a complete H&P. There may be labs you want to order, liver function tests. We know there's increased liver enzymes are possible. For the baby, fetal evaluation, non-stress test, biophysical profile to help determine distress. Patient may need to be hospitalized for initial rest and observation while determining severity. Management, without disease progression, deliver those moms at 8 weeks. At 32 weeks, stabilize and deliver if indicated. You want to medically control the hypertension. Do fetal steroids for the lung development, especially if it's before 34 weeks. Prophylaxis for seizures. Magnesium sulfate, magnesium sulfate, magnesium sulfate, magnesium sulfate is the medication of choice for prophylaxis of seizures and preeclampsia. Headache and clonus usually precipitate seizures. That's why it's important. If your patient has a headache, new onset of a headache, you need to evaluate thoroughly. I think I left page 460 for your current, where you can get all of the different doses, when to repeat it, what to do next, all of that. I'm not gonna test you on that. I just want you to know if you're treating the blood pressure, you wanna monitor it with repeat blood pressure measurements and treat if indicated. If it is a sustained blood pressure of greater than or equal to 160 systolic or 110 diastolic, you need to treat them. Treatments of choice are hydralazine, labetalol, and nifedipine. Hydralazine, labetalol, and nifedipine. Hydralazine, labetalol, and nifedipine. I don't need you to know exactly. Take that with you on your clinic. Know the side effects of those when you're on clinic. Do not give labetalol to a patient with asthma or heart failure. Also be careful with nifedipine if you're doing magnesium sulfate, because it can cause hypertension. So just be mindful of those. Know the 3 that we typically use in pregnant patients. Fluid management. Watch the electrolytes carefully. You want to do strict intake and output monitoring to avoid pulmonary edema. Total IV fluid should not exceed 80 milliliters per hour. This is in the hospital. Watch the electrolytes, strict in and out monitoring, and do not give more than 80 milliliters per hour on IV fluids to balance out that fluid restriction, fluid overload. That's the end of the helping and stuff.
That's White,
Yes.
question. For the women who develop it postpartum, do we just medically manage?
So for my friend that her baby was at that point, I think 3 weeks. They say it happened in the first 7 days. She was several weeks postpartum when she had hers, and she had to go to the hospital. They kept her in the hospital for about 4 days and trying to stabilize the hypertension, and she was given blood pressure medicine. So Definitely want to treat them, but yeah, it can happen anytime postpartum. I think that the times that they give are not ideal, are not for everybody. They're very good. Did I answer your question? Yeah. Any other questions? Let's stop there. So we'll take more than 2 minutes. So we'll come back, we'll finish health, and then we'll go into